Folks, thank you very much indeed for coming along. Good afternoon and welcome to the Health and Adult Social Care Overview and Scrutiny Committee. Before we start these proceedings, may I bring to your attention some housekeeping matters. There are no expected fire alarms today. Therefore, if the fire alarm sounds, please follow the fire and emergency procedures that are applicable to the Council House. This meeting will be broadcast live to the internet and will be capable of subsequent repeat viewing. By entering the Warspite room, committee members are consenting to be filmed throughout the meeting and to the use of those recordings for webcasting. Please can I ask that you speak clearly and directly into your microphone when addressing the meeting so that the online participants and the public can hear, and that it is switched off when you are not using it. And all your mobile devices are turned to silent, she says, quickly getting hers out. Right. Can I ask, Elliot, any apologies for absence, please?
Yes, thank you, Chair. Apologies from Councillor Finn, apologies from Councillor Pengelly, and apologies from Councillor Nicholson. Councillor Hume is substituting today. Thank you.
Lovely, thank you. Now, folks, I have no chair at the vice chair at the moment. So can I propose that Natalie Harrison comes along to be my vice chair for the afternoon? The seconder, thank you very much, Philip. That's great. Natalie, can I ask you to come over? I think you probably need to bring your ID with you. Thanks very much indeed. Okay, so we've had apologies and moving on to item 2. Do I have any declarations of interest in regards of today's agenda, please? Councillor Noble.
I'd like to declare an interest. I work for Devford Hospital, University Plymouth NHS Trust.
So it's a personal interest?
Yes.
Thank you very much indeed for that. Before we carry on any further, I would like to welcome both Councillor Noble and Councillor Macleay to the meeting. You're very welcome. I gather I say permanent people on this panel, so you're welcome. But also to Councillor Hume, welcome to you as well for joining us this afternoon. And I hope you enjoy the session. Right, folks. Okay, so if we move now to item 3, which is the minutes of the public meeting that was held on the 16th of November. I'm proposing them. Can I have a seconder? Zoe, lovely, thank you. And I will sign them in a moment. There are private minutes for that 16th of November, and we've not got, have we got those at the moment? Are they there? They're in the pack.
Chair.
So again, I'll propose, can I have a seconder, Zoe, again? Great stuff. Thanks very much indeed. If there are any matters arising on the public minutes, can you let me know now? If there's anything on the private ones, we'll need to go into a part 2 session to deal with those. So any questions arising from the previous meeting? No, there we are. That's all right. Elliot, you can record that. So that, in fact, took me on to item 4 in many respects, because it's noting the changes to the committee that were approved at the City Council on the 30th of January, which was appointing Councillor Macleay, Councillor Noble and Councillor Nicholson to this panel in their various guises, shall we say. So welcome to everybody. So item 5. Alan, welcome to the committee. I think it's a long time since we've had your presence here, so welcome. And we have an update on any of the policy briefs that might affect this committee. So has anybody got any comments they would like to make on it? I appreciate it's, there's quite a few, isn't there really, Alan, that have cropped up on this paperwork.
Yes, there are. Thank you, Chair, and good afternoon, everyone. So the policy brief in your pack actually covers the period since you last met in November until the end of
Anybody got any queries about the policy updates? I mean, I think the committee, it would be beneficial for you to receive a copy of that latest paper, Alan, if you wouldn't mind sending that out
Yes.
to us. So whether you send it to Elliot and Elliot will send it out to us, that would be really useful, just so that we can understand it a little bit better, because it is quite far reaching, so that would be good. Any questions? No, you've got away lightly there, Alan. Thank you very much for joining us. Much appreciated. All right, and I shall certainly say to everybody, if they have any questions, to get in touch with you and the team to see what we can have. But of course, by highlighting the links, at least it means we can click on and look for them ourselves as well. So that's very useful. Thank you very much indeed.
You're very welcome. Thank you.
Risk monitoring report. Ross, I think the floor is now yours on this.
Good afternoon, Chair. Not a great deal to report. There's been a reduction in the overall number of risks on our strategic risk register. Those pertinent to the committee, though, have remained fairly static. I won't talk anymore because the paper's in front of you, so happy to take any questions as you see fit, Chair.
Thank you very much. I mean, no doubt we'll be quizzing Anna about the fragility within the social care, adult social care sphere and whatever in a minute. So I think that will be handled there. Anybody got any queries about the risk register?
Apologies, Chair, I'm just going to jump in. We've got some tech issues where the sound from Teams isn't going out online. So I'm going to request a quick adjournment to sort that out.
Okay, folks, you've got a 5-minute break then, and whilst we sort the problem out with the IT stuff, all right? Sorry, Ross, we'll come back to you in a bit. Wrong. We can't let him get
Chair,
away with it.
Chair, I think it's fair to say that the committee has had in its sights most of the main strategic risks over the last couple of months and going forward. So, not being grilled is perfectly acceptable, I would suggest.
I think that's a prejudicial interest there, Ross, that you just made there. Pauline.
Thank you, Chair. I'd just like to ask about, do we know how many cases of COVID-19 we've got up at Derriford Hospital?
That may well be something that we need to bring Ruth in for that. So can I just park that for 2 seconds and let Ruth do some looking into, oh, in fact, she's there. We are. Ruth, have you got any update for us on that?
Yes, I mean, definitely rates are increasing again of COVID-19. So we went down to a little bit of a minimum in early to mid January, I think, and rates have started to rise across the country since then. I don't know the exact number today, but I can certainly tell you that it's on its way up. I don't think it's at the maximum by any means, but it's about midway on the sort of curve that we tend to see. Joe may be able to come in with more precise detail than that.
Thank you, Joe. If you wouldn't mind coming in, that would be great.
Yeah, I can. We talked about this. Sorry, my microphone's on my head. We talked about this last week. On the 23rd of January, we were down to about 23 cases, and we're now up to about 80.
Thank you very much. Pauline, did you want to
we should.
there?
Yeah. Can I just ask what is Derriford Hospital's policy about people that have got COVID at the minute? So, for example, with people visiting.
So we have it. We do. People are able to visit at the moment. I'm sorry, I can't see who I'm speaking to. I can't see the camera, so apologies. So we do allow people to visit at the moment. We try to manage visiting times and volumes, particularly when we've got higher numbers, but we haven't stopped visiting.
Thank you.
May I just add to that?
That-
May I just add that, of course, anyone who has any symptoms of a respiratory disease, or in fact any other disease like norovirus or anything like that, is absolutely encouraged not to come into a hospital setting for really obvious reasons. So that, just to make that clear, so somebody who has COVID symptoms, we would absolutely discourage them from any sort of visiting. Sorry, just in case that's where the
Yeah.
question might have led.
Sorry if I've
I think,
misinterpreted
yeah, I
that.
think
We are,
it's from the
yeah,
perspective of patients within Derriford that Councillor Murphy raised that. So I think we'll follow that through separately. I think Councillor Murphy, all right.
I'm happy to pick up
Thank you. And
outside if that's
perhaps a
helpful.
conversation with Joe out of this meeting might be quite useful there. All right, Joe. So if you would let Anna have your contact details, and then I can pass that on to Councillor Murphy. Thank you. Right, anything else from that? See, Ross, you got away with that really easily. One cat being evicted, that is, I don't know if we have to report that. Okay, folks. Thank you, Ross, for your help today, and take care. Bye. Item 7, urgent and emergency care services. We've got a slide deck to come. So, Chris, you're there already, and so the floor is yours.
Thank you, Chair, and thank you for the time today to come back to talk to you. So this follows our last visit on this item back in July. Obviously, we're very much in the depths of what is a challenging winter for the health and social care system. But you'll see the slide deck that we've shared. There's quite a lot of detail there today, and a number of my colleagues are with us and on the line as well. We'll take you through some high-level detail around that, just to give you a bit of an update in terms of where we are around performance and some of the action that's being undertaken. We totally recognise that the system nationally it's very challenged, and within Plymouth it's not where we would want it to be, but there is some positive signs in terms of the work and the progress that's being made. But I'll hand over to colleague David first, who will take you through the ambulance position.
Apologies, is it possible to get the slides up?
They're all in people's packs, so we'll follow through.
Okay. So if I can take you to the slide. I thought it was going to be up in the panel, sorry. I'll just introduce myself first and then give an overview. My name's David Harper. I'm the County Commander for South and West Devon, looking after the ambulance service. If I give you a quick overview, SWAT is a regional service, and we cover 7 integrated care board areas. Devon is the anomaly in that, and the fact that Devon is split into 2 areas, North and East Devon and South and West Devon. Just for clarity today, the information that I'm going to provide is a breakdown into South and West Devon County. And the South and West Devon County covers the area from Dawlish down through Tinbridge, down through Torbay, into Plymouth and up to Tavistock. So any information I provide today will be covering that area. I'm going to run through half a dozen slides, and I'm going to cover off activity, emergency department conveyances, resourcing and performance.
Sorry, can we just say it's starting on page 14 of the slide pack that we've got.
Apologies.
Thank you. Sorry, carry on, David.
Okay. The slides are quite busy and there's quite a lot of data here, so apologies, they're a bit busy. If I begin with an activity overview, when we were last here in July, I highlighted that we'd seen a significant increase in ambulance activity, particularly across the summer of 2021, where it peaked at over 400 incidents a day. This wasn't only within South and West Devon as a county, this was replicated throughout the full SWAS footprint. I'm quite pleased to say that since then, last year, the activity returned to much closer to expected levels. And in fact, in 2022 to 2023, it was closer to the pre-COVID-19 20, so it was where we would expect it. However, I have to highlight, we saw a particular increase again in December 22, where we rose to about 380 incidents a day again putting significant pressure on the system. I think that was down to the fact we had quite a flu epidemic, we had COVID raised its head again, and we had the incidence of strep A. So that pressure on our system coincided with the pressure on the rest of the wider healthcare system. If I could just take you to the next slide, please. I'm going to cover off here activity and balance that against emergency department conveyances. What I will say here is even in December when the activity rose, we conveyed about 34% of the patients that we actually seen to hospital. So a lot of our patients were dealt with. We had increased focus in the clinical hubs, so the call takers, and our hear and treat and see and treat were raised. So we only conveyed 34% of patients to hospital. After December, we saw a significant drop off in January. And I think that's, apart from the flu and COVID coming to an end, there's also been a lot of media coverage just around the pressure within the health system and obviously the industrial action. And we've seen quite a significant drop off in the public demand. In the 4 weeks pre-Christmas as opposed to the 4 week post-Christmas, I saw a reduction in calls to the public within the southwest Devon County drop by about 25%, which is quite a significant impact. If I could take you on to the next slide, please. It just covers conveyancing. Now, when I talk about conveying resources, I'm looking at frontline ambulances. We've seen quite a significant increase across SWAST in the amount of vehicle hours that we're actually putting out on the road. In 2019 to 2020, we were putting out about 37,000 hours. That's now increased to 48,000 hours, so it's nearly a 25% rise. And again, that's been replicated across South and West Devon as a county, where it's now putting out, we're funded for 5,400 hours a week. And if you look at the bar chart there, it shows we've had a couple of dips, but more often than not, we are seeing we're putting out more than 5,400. We're using agencies and we're also targeted overtime at periods where we know we're going to have quite an increased demand. I'll cover off performance now because that's obviously how we're measured. And the next two slides are very similar, but I think it's important to cover off Category 1 and Category 2 performance, which you'll hear spoken about. I'll just, a Category 1 call, just to make everybody aware, I'm sure most people know, but a Category 1 call is a call that's classified as life-threatening and it needs immediate intervention. We've got national targets for that, and the national target is 7 minutes for a mean response and 15 minutes for a 90th. The graph there shows the correlation between handover delays and performance. If you look at the top graph there, sorry, is that one there? Oh.
Sorry, Chair. Yeah, go on, sir.
I don't understand why we've got data from Cornwall and Isle of Scilly on the bottom of these bar charts.
The data isn't, it's the slide pack because obviously the area covered in terms of the UHP footprint for UEC. So it's just the logo on the slide deck.
Okay.
No, it's not your fault, Paul, David. It's the system here that it's been a little bit niggly for the last few weeks, quite honestly. So yeah, if you want to put your speaker thing back on, David, that would be useful.
Sorry. Okay. Well, that slide deck is quite a busy slide deck, but if you look, the blue bars there are showing you the time lost at Derriford Hospital, the orange is showing you the time lost at Torbury Hospital, and the red line shows you our Category 1 performance. What I will say here, and it's quite important to highlight, particularly relating to Derriford, is it covers all patients who attend Derriford Hospital. So it could be patients coming there for East Cornwall, it could be patients coming there to access specialist pathways. So it's not just within this area. I'll move on to the next slide, which is a very similar slide, but it covers Category 2 performance. And this is where there's a great deal of media and public interest at the moment. And just to clarify things, Category 2 calls are classified as serious conditions such as a stroke, a chest pain, which requires rapid assessment and urgent transport. The national targets for that at the moment are set at 18 minutes for a mean response and 40 minutes for a 90th response. I think that graph, it's more evident to say that the longest response times relate to the increased handover delays. They said earlier that we were aiming for a 30-minute response time. We did have a particularly difficult time during December. In December, 50% of our patients waited in excess of 2 hours for a Category 2 response time. What I would like to highlight here is since we've seen the drop-off in demand post-Christmas, we've seen a reduced impact in the handovers. And the week commencing the 23rd of January, within this county, you had a Category 2 response time of 21 minutes. And one day that week, for the first time in a long time, I actually saw us come in below the national targets. So we did see a significant improvement when it dropped off. And if I just come on to the last slide that I was going to run through, apologies. This is just a slide kind of showing you the handovers waiting at Derriford Hospital. Again, it's a busy slide. It's a blue one there. That's not the maximum amount of ambulances, that's the average number of ambulances that are waiting outside the hospital by hour of day. But I think what you can see there is the top of the numbers are quite dark blue. But we have seen since I think it was the 11th of January, we've seen a drop off in delays, which has had a significant impact, and we've seen an increase in performance, although we still have periods of high demand. Okay.
Thanks, David. So then the next slide lists just a few high-level actions that are underway in terms of support within the system to improve around improvements for ambulance handover times. So you can see that's focused around increasing the activity for same-day emergency care, and there's already seeing some improvements as a result of that additional activity that we've got in place, and also pathway improvements around admissions following 999 calls without the need to go into the emergency department, so avoiding the need to take people into the emergency department in order to get them to support through the other services within the hospital, and also looking at the fill rate in terms of the nursing gaps and improvements around that. So all of that obviously goes alongside the work that David has described there, in terms of that continued improvement that we want to see. So do you want to take questions now, Chair, on this particular section then?
Questions, folks? No? I'll be cheeky while Pauline's sort of getting things together there and thinking about it. When somebody is sat in an ambulance in the car park at Derriford, where does the responsibility for care lie? Does that stay with the ambulance service, or because they're parked and waiting for somebody to be admitted or taken into ED, is the hospital at all responsible for what's going on in that ambulance?
Yeah, the hospital is responsible from when the ambulance arrives in the forecourt. There's a 5-minute handover time. However, I will say it's a joint responsibility when the patient's still in the ambulance. It's collaborative between the hospital and the ambulance service. In light of what's been happening over the last little while, they have just introduced a system at Derriford, and Joe may be better placed to highlight it, but they've done a trial yesterday. I've not seen the data, but they've done some building work there because of the delays we have. And it's called RAT, it's Rapid Assessment and Triage. So the system's in place now where when an ambulance arrives, every patient will be offloaded, will go into the hospital, and they'll be seen by face-to-face by a clinician in the hospital. Even if that means due to capacity, they have to go back and wait in an ambulance. It means that everybody gets a face-to-face review within 30 minutes. But the building work only got finished last Friday, and the trial, as far as I'm aware, took place yesterday.
Thank you. Joe, did you want to come in on that response there?
Yeah, thank you. I mean, this is another example of as we see more demand, we need to keep changing our space. So we've changed our space several times, and to accommodate sort of different ways of doing things, Chair, just to try and do the maximum we can do in terms of seeing people as quickly as possible. It is a trial, but it is something we intend to continue doing, but we'll obviously adapt it to get the best performance. So we've had an evaluation at midday today as part of our site meeting. The nurses are all really pleased with the performance so far. The questions I've been asking is exactly what Davey just says. What happens when the department's full and the hospital's full and you still need to do a rapid assessment? And the plan is that patients will, if we do not have a bed, circulate back into the ambulance, but will have been seen. And at the moment, in terms of the shared care model, we currently have staff doing ECGs, bloods, and in the back of ambulances for patients that are waiting outside. So that is an active part of what we do anyway. What this rapid assessment and treatment model will enable us to do is also order some further investigations earlier on in that patient's wait for treatment.
Okay, so you're saying then that pre that trial that there was a medical practitioner or there had been a senior nurse going out to the ambulance to assess what?
Either. It depends. So we have advanced practitioners and doctors, of all grades that are deemed to be senior clinical practitioners who are suitable to be able to do those assessments. So, and obviously if a nurse goes out or an ACP goes out and that patient needs something else, a doctor will go in. But we quite often have the doctors doing a round of the ambulances or the nurses, someone going out to do ECGs and bloods and other interventions. And we've been doing that actively, as Davey says, because of our waits outside for quite some time. We've even had therapists go out.
And I understand there was some sort of outage at Derriford a couple of weekends ago. What was meant by
There was.
an outage?
Yeah, there was, and I was in the building on other matters. It was a Saturday, and there was a power outage to the server network, which is independently provided to a number of different areas, and it knocked out our IT, which meant that it impacted on our clinical system. So ability to order a scan, do a scan and read it properly and report on it, order bloods, order x-rays, everything. So it took us a significant amount of time to recover all those systems that day, and obviously caused quite a lot of disruption to patient flow.
So obviously, whilst any qualified person can take bloods, etc., then presumably it would be the reporting back that
It was
would
the
hit a problem
it's the
as well.
automated system, Chair. So on any blood now, for safety reasons, there's a barcode, and the barcode's read by the machine. And we had hundreds of bloods from primary care and from the acute that needed doing. The machines could not read the barcodes because of the IT outage. So we had to go back to priority bloods for that day, which were manually labelled and manually run and manually recorded, which meant we couldn't do the significant volumes that we normally do. Fortunately, we managed to restore the power and not lose the blood samples that we'd already got waiting, but there was a delay in reporting on them.
Thank you very much for that explanation. Pauline.
Thank you. Just following on what Joe said, actually, I think all the ambulances were actually diverted from Derriford also, because I'm 100% sure that day. And also patients in wards, their medications were being probably questioned because there was no computer system. So it was all done by paper, because I just happened to be up there in a ward when all of this took place. So that day there was no ambulances waiting outside because they were diverted to other hospitals. But that was,
Pauline,
yeah.
can I just come back on that? You're absolutely right. The EPMA, which is our electronic prescribing system, went down as well. We do have a backup plan, which is that we then print everything off. That took longer than it normally does because actually the server affected absolutely everything. So normally the wards can have their printers, but we've got 2 central printers, which we had to rely on for an hour while we restored the printers on the wards. There were delays to that. You're absolutely right. Although we diverted ambulances, we received 43 ambulances during that day because we'd already taken a number before it happened, but we didn't divert obviously life or limb because we're the major trauma centre. So we agreed that we would take those patients and there would be a manual review of scans and what we needed to do. So actually, even though we diverted, we ended up taking about 55 ambulances in total. But yeah, you're quite right. Thank you.
So thank you for that explanation. Pauline?
So my question was actually, do we know what the waiting time is now in the A&E department?
This moment, I can look it up for you, or are you talking about in general in terms of ambulances?
No, so obviously in A&E there's been quite delays for people waiting to be seen. Can you tell me what is the average now that they're going to be seen?
So we've got at present. So what I would share, if I look at ambulances first rather than walk-ins, if that's okay. So Dave is quite right. We had a very challenging December period, so demand went up, but also one of the things that we saw was that we saw winter demand plus COVID plus strep A plus flu plus norovirus all at the same time. Normally that takes about 8 to 10% of our beds out, which creates challenges to flow, delays to flow, and longer lengths of stay. And it was in the region, I'm talking about Devon as a whole, it was 16% for Devon. Everything hit at the same time. What happened after Christmas was and it was around the 9th of January, we saw a steep reduction in demand. So we've seen about 30 to 40 less patients a day arrive into the department. And at the same time, we've seen a drop in COVID, apart from this last week, a drop in flu. Strep A attendance has wore off and norovirus has settled down. We've still got some, don't get me wrong, but not to the volumes that we had. So that's improved our performance for 4 consecutive weeks. Unfortunately, then we had the outage. So up until that weekend where we had the outage, we'd had much better flow, and we were probably losing 50 to 80 hours a day for ambulances rather than the sort of 200 hours that we've been using. And on one day, as Davey said, we were down to about 25 hours. The average time to seeing someone on arrival is around about 25 to 30 minutes. The challenge we've got and we've had during December is if we've had a lot of walk-ins. So when we hold ambulances for any period of time, more people that are sick walk into the ambulatory part of ED that actually probably should have come in an ambulance. So then what we find is we're trying to sort out how we clinically prioritise patients who need admission. So you've got patients who are sick in the ambulatory area and patients who are sick in ambulances. Both need a bed, and then we have to work out with the doctors who gets the bed first, because there's a clinical prioritisation process that makes the waits longer for those that are walking in that aren't as significant a priority. So it's been really challenging. I would say performance has been much better in January, but we've still got a way to go. And obviously, at the same time, we still have to operate on people that are sick. We've still got to get our elective surgery admissions in, and that's also a competing challenge in terms of clinical prioritisation. Sorry, I'm going to cough.
Thank you for that. We've jumped a little bit there because there's a section on same day emergency care a little bit later in the slide deck. Any more questions for David and Chris there? Natalie?
My question relates to page 16. You talked about the amount of patients that were conveyed to hospital, and said that a lot of it was down to the different types of delivery that you were able to perform. How much of it is actually about personal choice? Are potential people that could be conveyed to hospital choosing not to go to hospital? Or is it because of other sort of actions that you're putting in place?
I don't have that data. When we go, I mean, all I can say is we transported 34% of our patients to ED. I don't have the data around how many patients refused, or how many patients that we spoke to in a emergency operations centre that we diverted to another pathway. I can only tell you the actual incidents we went to, we transported 34%. So I'm sorry, I don't have access to that data.
Just a supplementary, sort of following on from that, really, based on the reduction of conveyancing and your ambulance crews working with people at home, there was an increase in sort of the amount of time of ambulance hours of your crew. Has that got any correlation with the fact that maybe you're not conveying them to hospital, but actually you're working with them for longer at home?
Yeah, there has been. We've seen an increase in what we call our on-scene times, and we've seen quite a significant increase in the on-scene times while the crews try and access different pathways or try and manage the patient at home without a visit to ED. We've just actually run a trial for about 8 months now, and we've put something called a delivery cell within the EOC now, and what that does is we've got access to senior clinicians, specialist paramedics, and delivery cell officers who will monitor the on-scene times of crews. And it's called a stack report now. And as a crew is approaching 60 minutes, they will make contact with the crew and they'll say, right, have you got a plan? What are you doing? Where are you going? Is there anything we can support you with to try and reduce that and manage it and look at single points of access where we can, if it's possible at all, release the crew and somebody else who's office based will pick that up and say, right, I've got the details, I'll now follow this up and do it there. But that's where we're going with that at the moment.
Okay, no other questions at the moment. Great. I think the one thing that we've all appreciated is the dedication of the crews that attend any of these calls, and certainly noting that many crews had left picket lines to go and collect people. So, you know, our thanks for that, and certainly this committee has always been very supportive of what's going on within the health services in Plymouth. So please send, well, certainly my personal thanks to the crews for trying to do a very difficult job in very difficult circumstances.
Thank you very much, Chair. We'll cascade that today to the staff.
Okay, who's now going to take the next bit? Chris, is that still staying with you?
So Joe will start, but we'll have a change of chairs here.
Joe, if you can tell us which page you're starting with, it would be quite useful. All right.
I'm just checking. I had a moment of doubt there. I'm assuming you're meaning me, Chris, rather than Joe Beer.
I don't know, it becomes a bit confusing, isn't it, with so many Joes, quite honestly. We're starting from page 2, folks, I'm gathering.
Okay, so starting with me.
Yeah, it's for Joe. Yeah. Thank you, Joe.
Joe Turner,
okay,
sorry.
Lovely, thank you very much. So yes, so I understand you've had the presentation slides in your pack. So we're not presenting them here, and I will assume everyone has read them. So I won't go through them. There's a lot of detail. Last time you invited me to come, I think it was just before the new provider came in October. And we talked through the process that we've been through to identify that new provider through a procurement process, and the work that had gone into setting a specification with engagement from patients and system partners. We were confident at the time that we would have we would be able to work with that provider, have an improved service for over this winter period, and in terms of, and I suppose the point in me coming here now is just give you a little bit of an update about how that's gone in terms of working with the new provider and the impact on the system as well. Pleased to be able to say that we're working really well with the new provider, got very good relationships. They've been working with us in terms of delivery over the winter period, which has been really challenging. So we knew the first few months when they came online, we knew that there would be a transition between the old provider and the new provider. So we knew that there would be probably about an 8-week run-up period in terms of seeing some really significant improvements in terms of the 111 performance, which we have seen. We knew this winter would be really difficult. We didn't quite anticipate the levels of demand that the new provider saw. So along with the rest of the health and care system, they saw days where demand just significantly outstripped anything that we could have planned for. So there were times, particularly in December, where we did have some difficult days, but overall really happy to be able to say that the call answering and the abandonment rates, which are the things that we get monitored on nationally and that we report locally, are much improved from where we were this time last year. So really good, really positive news story there. I think though the bit I will outline are some of the challenges at the moment, particularly around the face-to-face aspects of the out-of-hours service. So we knew probably the biggest challenge for the provider would be around recruiting primarily GPs, but not just GPs, to some of that face-to-face out of hours care, and that has proved a challenge. So whilst we've seen I think really good 111 call answering performance and also validation of calls, so being able to downgrade calls from calls that originally assigned to go to either the emergency department or to an ambulance, they've done really well at being able to validate those calls down through clinical triage. So that's been really successful. But as I say, the bit that we are playing catch up with a little bit are around the recruitment plans for clinical staff to undertake some of that face-to-face. And we're seeing that transpire, particularly at the beginning of the week, probably as we're going into in-hours primary care is opening up on a Monday, and certainly are getting some feedback. There are some improvements that we need to make around processes, but also, as I said, need to deliver on some of those recruitment plans. So my team met with PPG, the provider, last week, went through those improvement plans, starting as well to see some real successes as well around recruitment. So really pleased that we got some green shoots there. So I think that's all I was going to say, Chair. As I said, I wasn't going to go through the slides because everyone's seen them, but happy to take any questions.
Thank you very much, Jo, indeed, for that. Any questions, anybody from that? You've stunned them into silence. Will.
Hello. My question, so you've got the sort of the service metrics you were rating the last provider on about call abandonment and average speeds to answer calls. Then you were talking about there about so I'm just trying to find the bit on there. Basically, what's the role, the 111's call service? What's its role, and are there other metrics to look at? Obviously, it's about people being able to call there, and like you were saying, people can call, and then if you like get sent, or what word you would use it to use other services other than perhaps going straight to emergency department. Is there a metric that you have for that? You were talking about calls being downgraded in category, so I'm probably not using the right terms.
Yeah,
there,
I mean, some of the calls that go into 111 are often about dental things, aren't they? For instance, that you then deal with separately. So I think that is that what you're sort of meaning, that, that others, rather than just advice and guidance, is there anything else that gets diverted?
Yeah, it's about this. I suppose it's about the effectiveness of because people are calling about their health. That's quite important, and I suppose it's the effectiveness of rather than just how many seconds it's call answered in, or whether people give up and phone again later. You know, that it's the sort of the purpose the service is providing rather than you know, call centre.
Thanks very much, Will. Yeah, Joe, any of that?
Yeah, I think it's a really good question, Will, because too often in the health and, you know, not different from some other sectors, but we tend to measure and are fixated on the process measures, and they are the things that we get unfortunately get rated on nationally without maybe looking at the other end, which are the outcomes for those individuals. And actually the national specification is very much focused on some of those process measures, unfortunately. But I think as we work with the provider, we have set things in place through the improvement programme that will start to collect things around outcomes and especially experience for people as well. One of the things I would point to, just on your particular question about kind of other services and things, and not just looking at, you know, how quickly you answer the phone, do the calls get abandoned? So on page, I'm not sure what, yes, I think it's actually page 8 of your slide deck, I believe, in the supplementary pack. I will just point out the disposition. So these are people that would have gone to ED or would have gone to SWAST if they hadn't been clinically triaged and validated. So so as you can see there, there's a national target of 50% for both of those. So downgrading patients by 50%. We'd set a higher target locally, so 75% and 85%. But as you can see, in October and November, so apologies, this data is a little bit older now. We are, the provider are, you know, broadly achieving those local targets. What that does mean is primarily those patients will get then either referred to other services or will receive advice and guidance, as you say. What we're starting to look at and starting to understand is where else are those patients going. Some of that will be about primary care, some of that will be dental, you're absolutely right, some of that might be mental health services. But I think that's the next stage, Will, for me, is understanding, getting underneath the process stuff and really understanding what are the outcomes for individuals. Have people benefited from using this service, not just as a kind of signpost and a sort of post box and a way of avoiding people going to ED, but actually what have people benefited in terms of their own health through these services? So I think it's a really good question.
Thank you very much. Anybody else with Natalie?
So it follows on or goes, I think it's pre what Councillor Noble is asking. Do we have any data on how many people may be calling 111 having already called 999 and then being told to call 111? Please.
Yes, so the way, and actually you've got someone in the room in Davey actually might be slightly better to answer that specific one than me. But what we're trying to work on at the moment is how we can, so if a patient goes through to 999 and actually they would be more appropriate for 111 rather than actually making that complicated from a patient perspective, is how we could directly electronically transfer those patients. So from a patient phoning up 999, they don't need to either rephone a different number or don't need to wait for a call back. Is how we could do that electronically, and that's one of the things that's in the improvement plan at the moment. So yeah, I think from a patient experience perspective, that's really important.
David, any update on that?
No, apologies, I couldn't answer that. That would be an EOC thing, and I think it's calls going the other way as well. But I know there's a lot of work going on at the moment with PPG, and we're having fortnightly discussions with them just around teething issues to try and ensure that it works from both sides.
Thank you.
Thank you. Unfortunately, it does cause a lot of distress, particularly when the outcome is not good at the end of it, if someone is asked to then phone another number.
We'll look forward to hearing more of an update on that, Joe, as that develops. That would be an excellent service. Anybody else got any questions? No? Joe, thank you for that update so far. I'm not too sure whether you get away now scot-free or whether we need to be roping you in for anything else, but thanks. It's always good to speak with you. Thank you.
Thank you.
Right, who's next?
So the next section's on admissions avoidance. So that is slide 22, and that's with Ian, Sarah, Joe and myself.
So I'll hand over to you, Joe, just to kick off, and then Miss Sarah and I will pick up.
Brilliant. Yeah, thank you. So just in terms of our MIU and UTC activity, you can see from these graphs that there's not been significant increases in attendances, but we have focused a significant amount of effort in terms of training up the staff, and we've appointed a primary care clinical lead for our UTC, and they're spending a lot of time talking to general practice about what the options are to be able to support general practice in some patients' pathways away from the acute provider if that support's needed. So we've seen pretty static attendances for the last few months, but actually in a compressed number of hours. Attendances at Kingsbridge and Tavistock have been increasing, but again, in line with normal seasonal variation. I think there's more opportunity to think about what we can do with UTC capacity more closer to Derriford, where we do see a lot of walking activity that potentially could be managed through a UTC arm, which would free up some much needed space in our urgent care department in our ED. I'll hand over to Ian.
Okay, thanks, Joe. So the next section, Sarah in a second is going to come in and give an overview of our community-led avoided admissions. So this is predominantly our older adult activity, and then I'll come in with some of the mental health avoidance work, and then we'll wrap up with James. We'll just kind of pick out some of the projects that we're doing to drive improvements. So Sarah.
Thank you. Good afternoon, everybody. I'm Sarah Pearce. I'm one of the Assistant Directors in NIFR South West. So just going to talk you through the slide on community care-led avoided admissions. So these are teams who provide urgent crisis response, so community crisis response team, and also, so they work from 8 AM until 8 PM, 7 days a week. And then we have our 24/7 urgent care nursing service, who provide technical nursing in the community, such as fluids, IV antibiotics, enhanced observations, and also through the night, out of hours district nursing treatments such as palliative care, end of life care, catheter and bowel care. So that's kind of what the team is made up of. So all of the people who come through those teams ideally stay in the community and don't go up to the hospital. So for community crisis response, we have maintained our activity. So in Plymouth, we were pretty much at the national standard. So there was a new national standard last winter to provide 8 till 8. And ahead of that, we were already providing 9 AM until 8 PM weekdays and 9 AM until 5 PM at weekends. So we've built the team up and been able to increase the hours of activity. And we work both in the community, so we receive referrals from SWAS colleagues, from any primary care colleagues, from any community colleagues. But we also have workers up at the front door of Derriford Hospital. So if somebody goes up to the emergency department, wherever possible, we work with our colleagues at the front door to be able to turn them around and take them back home, you know, wherever we can. So multi-professional teams, physios, nurses, occupational therapists, social workers, general support workers. So a real mixture of skill across the teams, and the teams share skills, so we get the most out of all our responders. So you may get a response from a social worker, but that social worker will have some skills in basic clinical assessment, basic equipment assessment, as well as their knowledge as a social worker. So a really multi-professional offer, and something that we're building on. So the urgent care nurses at the moment are taking part in the virtual ward work. So this is about more technical skills at home, and I'm sure you will have all heard in the news about the desire to grow virtual wards so that people can have care in the community. So, you know, we anticipate that our avoided admissions will grow as schemes such as virtual wards start to grow. So you can see that we've kind of maintained our consistent level, and you can see the kind of, you know, what that equates to on a daily basis, weekly and monthly basis. So I think on to the next slide, please. Over to you, I think. No, that's still me, sorry. I can't see you with my glasses on, but I can't see the slides without them. So we could see there, we talked about the UCR, so there's a urgent crisis response standard national guidance. We have two main targets to hit. One is for people who are in crisis and at risk of admission to hospital, to actually assess them within 2 hours from referral. And you can see there that we've, for quite some time now, managed to get over that line, and we've been able to see people within 2 hours, which obviously means if we can see them within 2 hours, they're unlikely to go to the hospital.
Sarah, can you just explain what sort of patient that is?
Yeah. So an example may be somebody who has had a fall at home. They've had an initial triage, so we may well get that referral through SWAST to say that this person has fallen at home. From our initial triage, it sounds like they've got what we call a non-injurious fall, so nothing that needs hospital investigation. So we would accept that referral. Our responders, so as a professional responder, would speak to that person. If that person has got digital technology, we can see them. If they don't, we talk to them on the telephone. We can assess then, whether we need to go and see them. And for a faller, we would generally go and see them because they're going to be on the floor. So we have all of our team are trained up in falls response and falls assessment training. So usually for a fall, we would send 2 workers out, one of our support workers and one of our professional responders. They would go out, they would do the top to toe assessment, check that it's safe to move that person. They have access to great lifting equipment, so they can get somebody off the floor with a piece of kit. We've got some razor chairs, we've got a hover jack, we've got different bits of kit, and they get the person off the floor onto a bed or a chair, wherever they're most comfortable, and then they would do that assessment of what led to that fall, what's happening for that person, check their medicines, check they've got food and drink in the fridge, just kind of check out if they're doing okay or if they need a bit more help. Then depending on the circumstances, if there's family around to help, if they've already got carers, they would link in with, the people who are around that person. They would keep them on the caseload and just check out how they're doing for the next few days. If that's not the case, our options are, if that person needs a little bit of additional support at home, we would see if one of our general support workers can actually bridge a package. So whilst we're waiting to get a package of care for that person for short term, our carers would actually deliver that package. The carers actually work up until 10 o'clock in the evening. If the person isn't well enough to be left at home but doesn't need to go to hospital, we have admitting rights into our short-term care centre. So we can admit somebody into a bed where they can have reablement care 24/7. And if they're a bit more poorly than that, we can also admit them into a care home. And the community crisis response team then have that person on caseload, follow them up, send in whoever needs to go. So maybe they need a bit of nursing, they need a bit of therapy, they need a social care assessment. So the team would hold them until they can get them back to where they would normally be.
Okay, Sue, you want to just ask something?
Thank you, Chair. This community care-led avoided admissions, admission avoidance, does it work through the night?
So the UCR, the Urgent Crisis Response Team, they work from 8 a.m. till 8 p.m.
That's daytime.
That's daytime. And then our Urgent Care Nursing Service work 24/7, so they work through the night. So there are some things, so if there's a falls response from the 20th of February, we're going to have a 24-hour fallers response, and they would respond to people in crisis at home. So if there's somebody who isn't very well at night, they can go and have a look. They get their referrals through Devon doctors at night, and also through SWAST.
And are there ways, if you imagine, say, an elderly person has sort of fallen out of bed and it's cold, they're not going to get a phone, but maybe they shout or something, I don't know. But how long would that take, given the staffing levels?
So within 2 hours. So the graph,
2 hours.
Yeah, so the graph on page 27 shows that. So if somebody's classed as an urgent response, so if they're a faller, then they would be classed as an urgent response. We would need to get to them within 2 hours. So you can see that pretty much since June of this year, we've managed to achieve that for more than 90% of cases, that we've got there within the 2 hours. And if we don't physically get there in the 2 hours, we will have spoken to the person within the 2 hours and they'll know we're coming.
Okay, so what happened before June?
We didn't have
Oh, you
such
didn't?
a big team. Yeah, so we've grown the team. Yeah.
All right.
Can I
Thank
just
you.
quickly come in on that? So we did a piece of work with SWAST probably just over a year ago now, where we were looking at the call stack. So we got different multidisciplinary teams in, the UCR team were involved in that, to look at areas where we could increase provision. So we saw a lot of fallers, and particularly out of hours, hence why we put some funding in to support the out of hours nursing team and train them up so that they can provide a similar service to which they do in the daytime. Otherwise, those individuals would have been picked up by SWAST and likely ended up in ED.
Thank you for thank you for those answers. It seems to me the vulnerability of an ever increasing upward trend for ageing. Is there any way that the people could get preventative care that makes them sturdier, makes them more resilient, and so that they can they don't fall and they're not so frail? I think something. I mean, it'd be interesting if you had anybody had the time and the money to do a sort of pan-European look at what happens with elderly people in different cultural contexts and money and all the rest of it. But
I guess that's the other half, or another part of my job. So in another part of my job, I look after the locality services. So these are the teams that do that more preventative, long-term work with people who live in in the communities. And I think we've been doing some work to really help us separate out the urgent care and the locality work, because the person on the floor always shouts loudest, they're always going to need to be seen first, but actually we really want to be able to balance that with prevention. So we have been rearranging our community teams to work in a more integrated way. So our community therapists, our district nursing, our adult social care colleagues, our long-term conditions specialist nurses, are all moving into kind of working together, more closely together, and also wrapped around our primary care networks with our GPs. So we have something in Plymouth called Aging Well, which majority of our primary care networks are now signed up to and will be signing up to. So Aging Well is part of a frailty prevention strategy. So so it's exactly the kind of thing that we need to be focusing on. So looking at people who are at risk of moderate to severe frailty and putting a plan in place with them, hopefully before they have that first fall or after they've had that first fall, to prevent and work with them. And we work really closely with some of our community partners, so partners like the Elder Tree, who do some really great falls balance work, so we can link people in. Our community therapy workers have just done some positive aging events where they've gone to church halls and they've kind of just done some really great, this is how to look after yourself now you're getting a bit older, now your bones are getting a bit snappier, frailer. So a lot going on kind of either side of the fence. I guess for today we'd been asked to focus on the urgent care, but I think it's important to let you know that's going on as well. Yes, absolutely, yeah.
And do you see the new government announcements about looking after people more at home being something that your service is going to have to look to expand to cope with that? And so I suppose it's coming back to workforce, and do you think you're going to be able to recruit?
Absolutely, Chair. I think that is one of our biggest challenges. Workforce across all of our partners is a really great, it's a big challenge for all of us. I think we've got some really great experience of growing our own. The difficulty with growing your own is people aren't ready tomorrow, but the more we invest in growing our own means we will have a workforce fit for the future. And we've just started off in line with the National Workforce Plan to look at our Live Well Workforce Plan and looking at that with our partners across the ICS about what kind of workforce do we need for the future to make sure we can kind of meet the challenge. Yeah, a bigger one, and one where people can do more in one visit. So those skills, enhancing those skills, learning from each other. We've got a great example where a social worker went on one of these responses because they had done training and were competent in doing clinical observations, they recognised a person had sepsis. They were able to escalate them to hospital. Yeah, a few years ago, social workers wouldn't have known how to do that. And they recognise that as part of, you know, that holistic assessment for that person. So yeah, some good stuff going on. Thank you.
Gary, and presumably your team is all linked in to all of this, and you're very much aware and part of the conversations going on.
That's fine. I think these are a part of the system development changes, aren't they? And all of the work that we work on together through the whole partnership arrangement. Yeah.
Good. Thanks very much. Sorry, Sarah. Carry on.
No, I think I'm handing over to Ian now. Thank you.
Right. So I'm going to walk you through a snapshot of our mental health data. A bit like Sarah said, this is obviously not the entirety of what LiveWell provides as the main mental health provider, and picking up the other points earlier on. I'll try to cover off some of the questions I might anticipate, because we're going to have another slide now about call dropout rates and things like that. But there is obviously a much bigger picture in terms of mental health that we aren't covering. So this is very much focused on the activity that is intended to offer an alternative to people who are experiencing a mental health crisis other than accessing the emergency department. So that's what you've got included. Obviously happy to take questions about anything else outside of that. So the slide that we're on at the moment is a snapshot of our mental health first response service. This is a 24-hour, largely telephone response service, but there is option for face-to-face assessments. It has a combination of registered mental health nurses, social workers, as well as multi-skilled call handlers. The other thing that the service does since April is it provides an infrastructure for the approved mental health professional service, which LiveWell now runs on behalf of Plymouth City Council 24/7. We've been able to utilise the fact we had that existing service there to make efficiency, so we've got a kind of combined offer overnight for those individuals. In terms of the performance, you can see there that the service is monitored in terms of calls answered, and you can see that unfortunately that tail dropping off right the way down towards the end of the year and then taking an upward turn in December. So that corresponds with increasing call volume mainly. So you can see that the greater the calls we get in, which is what we want, the harder it is to pick all of them up. I'll just draw your attention to the slightly squiggly slide in the bottom right hand corner, which is actually probably the most significant one. There's a separate performance indicator sitting behind that for the service, which is a national indicator, which is around calls that are abandoned after 60 seconds. And the reason that's there is quite often people, having heard the preamble about what they're dialing into, will think, oh, I've got the wrong number, or that's not for me. And usually if somebody is in a crisis, 60 seconds is a reasonable amount of time to wait. So the number of people that abandon calls after 60 seconds is actually well within the less than 5% measure. So I think in terms of assurance that for overwhelmingly people that are in a crisis get a response, that is the case. And again, we benchmark fairly well for that service. So as I say, that's not the whole entirety of our mental health offer, but that's the 24/7 component. And to pick up, to answer a question that hasn't been asked but was raised earlier, what happens after all of those calls are finished? So we either are able to resolve the person's crisis, bearing in mind it can mean a crisis means very number of different things to different people. We'll either resolve it there and then, or quite often if we identify somebody could benefit from one of LiveWell services or indeed support from other partners, we'll directly refer them into those services. So we don't say to them, off you go, ring this number, we will take responsibility for that. And there are regular meetings within the week between the teams to make sure that that happens. So all of the teams at LiveWell meet with first response team, and our primary care mental health team, which is the part of the service that sits very much within GPs, has a very close relationship with that service, so they often pick work up from each other. Okay. So you can move on, please. Okay, so the graph on the top left, this is still a relatively new offer and very reasonably low numbers going through it, but again has been successful. This is our alternative to the emergency Alt to ED service. So it's in a building very close to the emergency department around the corner. So if somebody were to, having not taken advantage of the first response service or not been able to get support through the usual channels, but did find their way to ED, and they're there purely because they're in a mental health crisis, there's an alternative environment that they can be signposted to, which is quieter, calmer, where they'll be assessed by a group of mental health experts. So that's what that service is. And again, you can see that referrals have gradually increased. On the right-hand side, this is our in-hospital activity. So Livewell provides a psychiatric liaison service that operates both within ED but also in the hospital itself. And after a period of worsening performance, you can see that things have started to tail back up again now. And in fact, for this month, although it's not in the graph, we will have hit our target for the first time. So that target is really about the speediness of our response to getting to those individuals. And that is the quick run through as far as mental health is concerned. And then I think the final slide, we've just got a bit of a summary of some of the improvement actions taking place.
Yeah, that would be great. So could you put it on to the next slide? Thank you for that. So yes, there's a lot going on in the world of admissions avoidance, and there's lots of different teams and organisations included in that. We set up a People First project in December 2001, and that's the kind of improvement project that we're working on, which covers across admissions avoidance and brings people together on a bi-weekly basis to look at some of the data and performance and give teams the chance to share what they're doing, get feedback and link people up. So that's worked really well, and what that does is keep the vast amount of different schemes and teams that we've got under one umbrella so that we're communicating with each other well. So key, as we've spoken about previously, is just increasing the use of those alternatives to the emergency department, and we've heard about different services. So the UCR service, we've got urgent treatment centres and minor injuries units. So on site at UHP, there's a SWAST role. It's called a halo. This is kind of a coordination role. So when people come in within an ambulance, we can have a look at those individuals and hopefully use some alternative pathways for them. Obviously, we would prefer to get to those people when they call in the first instance and divert them to another pathway, but that's in place. I won't talk to mental health and SDEC because obviously Ian's referred to that, and Joe's picking up same-day emergency care. Around the urgent treatment centres and minor injury units, there's been a lot of focused work around improvements there. A year to 18 months ago, suffering from staffing issues, and we're having to close that service on a quite regular basis. There's been a lot of work that's gone into recruitment and training to ensure that people can be directed into the urgent treatment centres. Some work with SWAST colleagues around that, and really pleasing to see that the closure rates have dropped significantly to under 1%, and it was up at about 25% 18 months ago. I guess key to being able to locate patients to the right pathways is having the right information. So there is what's called a directory of service, which colleagues in SWAST can link into. So when they're looking at a person with a certain disposition, they'll be able to find an alternative pathway, and SWAST, along with other colleagues in the ICB, are working hard on making sure that's easy to understand for individuals out there. There's loads of different services and pathways people can go to. So that's ongoing. We've got a primary care ambassador, a lady called Dr. Ruth Barth, who is clinical GP lead within the urgent treatment centre, and she's done some brilliant work with a colleague from SWAST in visiting all GP practices, both in Plymouth, the surrounding area, and indeed in Cornwall, talking to GPs around the alternatives. So, GPs need to be as aware as they can be around the alternatives rather than pointing people to the emergency department. Could you, next slide? Oh, I'm not sure we can do the next slide. Yes, we can. Okay. And then a couple of areas that we looked at in the summer were around frequent attenders for people to the emergency department, and we looked at data and did it by GP practice to see where most people were coming into the emergency department, and then drilling down in the data to see people that were frequently using the emergency department. Using a multidisciplinary team approach with the GP practices, with colleagues in the community, reviewing those patients and what really are their needs, what can we put in place to stop them needing to attend ED. So that's relatively early in its conception and is developing with Mayflower PCN, and we'll continue to roll that out. The other side of that was looking at care homes, so which care homes are admitting the most patients and why. We've commissioned a service called Immedicare, and that basically gives care homes a quick route to clinical advice, both online and in person. This scheme showed real positive results in other parts of the country, in some care homes saying that they reduced admissions by 50%. And we've rolled that out to, I think, it's 48 care homes in the patch, which is really positive, and we'll continue to monitor the progress. This is an out-of-hours service primarily, because we looked at the amount of people that rock up at ED after hours, and it was 69% of those. So, and we've had some good results, and we'll be happy to come back and share that at a later date. Sarah mentioned the funding that we've put in to support fallers, so that is just about to go live out of hours. I think that's probably it. There's quite a lot going on at the moment, and it's all, you know, done as a collective across organisations and in a joined up way through the People First programme. Happy to take any questions. Thank you.
I'm presuming that you've got a whole motivated workforce to take new initiatives forward, really, isn't it? Because to me, it's always an exciting thing to be pioneering something that you can actually say, I helped with that. And certainly all the help for care homes to know that they've got somebody at the end of a line rather than having to call an ambulance out immediately. I think that's got to be very useful from the care home manager's perspective, hasn't it? Any other questions, gang? Well, you've stunned them into silence. No.
It's not a question. I know you did say that you bring to a later meeting a list, you know, sort of information more about the care homes and how you were monitoring that. Are you also going to be doing that in terms of the GP practices as well? You mentioned Mayflower, but you haven't mentioned any of the others.
Yeah, as we roll that out. So basically through the People First programme and some other internal meetings, we monitor the progress against all of these schemes. So and we also have to report that back through to regional colleagues, etc. Because obviously we're spending money, we need to see the value that patients are getting out of that, and the throughput into those services to make sure that they're successful. As I say, that both of those services are kind of in the early stages, but they could make a really big impact. So yeah, we keep an eye on it, and we're happy to bring it back.
Thank you. Is that just going to be about those admitted to ED, or is it also, are you working with Health Watch or others that may find that actually there are issues?
We do work with colleagues in Health Watch, particularly around the surveys that they undertake in ED, and I think another one is planned. So all of that information needs to feed into our commissioning decisions, really, around and the areas in which we want to focus more.
Yeah, I think we did recommend that there was another Health Watch survey done at an appropriate time, didn't we? When we heard from you all.
I'm not entirely sure where that is. I know it's planned, but I'll find out and come back.
Thank you. That'd be useful. Will.
Oh, these seem to be quite good measures to prevent people going through the emergency department or even going into hospital. Because that can be quite disorientating for people, especially where it's been very busy recently. So as a patient or a family member, you've got a relative, how you're talking about some of the aging well sort of programs and things, but how do you think more needs to be done to make people aware that these things are available? So, you know, if a relative falls over, that they're not going to go, because it's got a sort of anxiety of somebody just having to call an ambulance is awful lot of anxiety for people, and older people perhaps value their independence, and if they're having to go into hospital, they see that as losing, and you've got that kind of resistance thing. Even my own family, a little bit like that in the past. So yeah, just.
It's a really good question. So one thing that does happen as part of ageing well is that patients on the doctor's list get sent a birthday card. So they get a birthday card to let them know what's out there and the services that are on offer. So that's something really proactive that didn't used to happen before. So I think that's quite a good thing that happens. And then the other thing that's really helped to centralise everything, because there are different offers, is that for patients now who think, you know, they may need to access services, they can access everything through NHS 111. So if they call 111, 111 won't automatically send them an ambulance. They will look at what they call their directory of services. So all of our services are on this directory of services, this DOS. So depending on what the caller tells them, so, you know, I'm at home, I'm really not keen to go to hospital, I've had a fall, I don't think I need to go in, but I need some help, they would be able to match them up and think, they need the UCR service, and they will put that, they'll take that detail and put them through and get them into the UCR service. So 111 is almost that kind of central place for, you know, the public. So that's why, you know, you'll see a lot of campaigns about Think 111, because actually if somebody's not in that kind of real life threatening emergency situation, then 111 is the place to go to get to the right place.
Anna, sort of thinking about the council website, etc. Presumably, we update that to make sure that it reflects different things that are in operation. So I'm just thinking, I mean, I don't know whether people automatically go to the council's website. I mean, it's probably the NHS website more than anything else, but I just think it's making sure that all partners are signed up to let people know.
I think so, and Sarah's point around having one point of access for individuals is really key. So Joe Tell spoke to us around the improvements in the 111 service, and we need to see that continue, because if we want people to trust that every time, they need to be having a good experience, and it's around regaining that confidence, I think.
Actually.
Yeah, just you spoke about 111, and obviously things like the health and the wellbeing hubs are obviously key to promoting things like the age positive programme, etc., and getting things out. And obviously I'm aware that, you know, some of them, Improving Lives, for example, very much are you know, sort of pushing the age positive programme, but certainly making sure that the wellbeing hubs who are out there in the community are promoting what is available already.
Yeah, certainly. Thank you. Yeah, and we work very closely with the wellbeing hubs and make sure that our services are promoted in them.
Okay, challenge to Anna, Elliot and Gary, and probably to John as well. Can we have some sort of good points for councillors so that they're aware of what's happening? Because I mean, obviously those of us around here today now know a lot more about it than we did. I'm just wondering whether the councillors' weekly briefing that goes out could perhaps have a potted version of what we've heard today.
Happy to take that as an action, Chair.
So can we put that down as a recommendation, Elliot, from today, please?
Noted, Chair.
Thank you very much, Lee. Any other queries before we then move on? No? Thank you. Thanks very much, Sarah, and team there for that. James, are you staying put for the other bits of it?
So we're going next to Joe Beard Chair, and then I think we're back on, so we may as well stay here for a little bit, but thank you.
Thanks, Joe. We'll move on to you.
Thank you. So I think if we go to slide 31, I don't really think this slide does us justice in terms of being able to explain the demand. So if I may, I'll just share a little bit more information on the discussion that we had previously. So demand has been more steady since the sort of last major peak of COVID. But as per my previous statement, what we've seen is a higher level of sick people walking in, predominantly due to the lengths of waits in ambulances. As we've seen a significant improvement in ambulance process and capacity in January, we've seen more ambulances arrive and less sick people walking in, which is the right outcome. But it does just show that when we are really overcrowded and we cannot get the flow through the hospital, that people come in obviously via any route, which is not how we want it to be. But it is we are currently sort of working through how that demand changes from one part of the emergency department to another, as we start to see improvements and hopefully sustain those improvements. If I can move on to the next slide, please. This is another key important area, which is the time to assessment. So the standard is that all patients should be assessed within 15 minutes. We do that more consistently for people arriving in ambulances than we do walking in. And as you can see, we're on an improving trajectory, but the progress that we've made on the rapid assessment and treatment RAT area in ED, which David talked about earlier, should make a big improvement in that if it works. So that's what we're currently working through at the moment. So the ambition is to get that to as close to 15 minutes as possible, and the bottom graph to have more patients, a higher percentage of patients seen within 15 minutes. Next slide, please. So I think this is the question that Councillor Murphy was referring to, but I've also looked at today's performance while I've been waiting, just so that I can answer, and then I'm happy to take any questions that I've missed. So these are the waiting times when people arrive in the department. So if I just do a step before, obviously before they get to the emergency department, there's been a wait for an ambulance, there's been a wait in the car park, then there's a wait in the department before people get to a ward. It's an experience none of us would want for our patients. It's extremely distressing if you're a patient or family member, and it's also distressing for the staff that are trying to provide care to patients when there's challenges with being able to see everyone. So we in December, once patients were admitted to the department, if they needed a bed, notwithstanding obviously the clinical prioritisation, the longest wait was 19 hours to get into a bed in the hospital. And then the meantime, if people were being discharged from hospital, was 6 hours. So a long amount of time to support people to get on the right pathway. What I would say in terms of context is for those needed admitting, and I know we've talked about this previously, but there are multiple factors in terms of that admission. So one is beds available in the hospital. Those beds during December have been full of people with sick illnesses, so people who are admitted with high levels of acuity and complexity, patients with COVID who have a longer length stay, norovirus, all these things restrict flow on top of a number of delays. So what that leads to in the department is a number of patients at any one time that don't need to be in the department, that need to be on a ward, that we can't move out to a ward because we don't have capacity. And that's been an area of particular focus for us at the moment, because ED are managing an emergency department plus at least 1.5 to 3 wards of patients that need to be admitted to the hospital. And then you'll see from the discharge figures later when James goes through that there's another amount of patients that were waiting to discharge from the hospital, and then there's some process improvements in the middle. I hope that makes sense, but it is a challenging journey for people that are coming in through the UEC pathway at the moment. Next slide, please. Sorry, and today's performance, there are no people waiting over an hour to be taken out of an ambulance. We've had a very positive day, but that's after 2 very challenging strike days, where on Monday we had a nursing and an ambulance strike. And I know you'll understand that certain areas are derogated as emergencies, but not all areas are. So that significantly impacts on our ability to to flow people through the hospital. And yesterday was an ambulance strike, and we have another ambulance strike on Friday.
Joe,
Shall I
before
pause?
we move on, can I just ask Councillor Murphy wants to come
Yeah,
in on
yeah, of course.
the previous slide.
Yeah, Joe, it's just about the waiting times. Unfortunately, I've had to spend quite a bit of time up at A&E recently. And while I've been there, I've been like observing what's been going on. And I just want to know, and that this might, and I might be out of order by saying this,
Yeah, of course, it's of course.
but I've noticed that when I've been sat there, people that have been brought in by the police, they get kind of like fast tracked, and we have patients sat there for hours on end, and we see, and I've seen this quite a few times now, and you can see the other patients there that are waiting to be seen getting really angry because they are still sat there and these people are getting fast tracked. Is there a reason for that? And I probably maybe get it is because you don't want them in the waiting room with these other people, but it's just not fair.
Yeah, no, it's not. It's absolutely not fair. And I don't think there's a straight answer to it, Councillor Murphy, if I can be honest. I think we've had times where we've had 4 lots of patients with double-handed police officers with them. It's really disruptive to the department, the doctors and nurses trying to provide that care. So on those occasions, I can see that they might try and treat those patients and you know, move them out the department because it impacts on all patients. But equally, I have had feedback that people get very frustrated if they can see that that's happening. So I will take that back to the department. You're always welcome to come and provide some personal feedback too. I think it's always really helpful to see it from an individual's perspective. But yeah, you're absolutely right. It's not fair. Sometimes it's just about how we manage the volume and the disruption to all of the patients in the department. And we've had a particularly challenging 2 weeks in terms of presenting patients. Does that make sense?
Thank you.
The only other thing that I meant to add when I started at the beginning is the Health Wash programme is starting next week. They're going to see 500 patients across Devon and 125 in Derriford. So if I move on to the next slide. Again, if you triangulate this with the slides that have been shown by Sarah and team, this is the number of patients arriving with mental health related illnesses and the length of time in the department. And again, there's multiple complexities around why people are in the department for a long time. But some of those are related to whether toxicology results prevent the appropriate assessment, but also the capacity and the volumes and complexity of patients arriving. So more work to do on that, which we're doing together, but we are seeing an increased incidence of mental health presentations at present.
Joe, can I just ask about the toxicology side of things? People that have come in with suspected drug, I don't know whether you call it intoxication or what, but then sit in the ED waiting area and then proceed to take more drugs. How are your staff able to deal with that so that, you know, they're compounding whatever they've come in, but they've obviously still got drugs on them that they then proceed to take further that then causes more of a crisis. So I just wondered how that was dealt with.
So we would have a 0 tolerance to people taking drugs in the department, and we have a security team that walk around regularly. I think our bigger issue is that people arrive having taken drugs or overdosed or being intoxicated, and you can't do a proper mental health assessment until those substances have worn off. Again, I think if there's any instance where people have seen people actively taking drugs in the department and not been resolved, I would want to know about it, but it's not an incident that's been reported to me.
Okay, and I think certainly with naloxone being one of the things that Ruth and the public health team are looking at is making naloxone more available in the community, shall we say, for known users. That may well help that. But I think that's something else that Councillor Murphy might well be having a conversation with you about, Joe. Okay. So
Yeah, very happy to do that.
thank you. Right, sorry, carry on.
Next slide, please. So again, this is an interesting slide. So we've spent a lot of time trying to understand, obviously, all of our delays position and what we could do better. And we have had support from the national team to look at our admissions through the front door of the hospital. And one of the things that we always challenge ourselves with is, are we admitting too many patients? Are we admitting patients who don't need to be admitted? And could we do something different? I think that the multiple levels of scrutiny that we've had recently and the additional actions we've taken through the strike actions and the recovery actions, which is by putting additional surgeons, sorry, bear with me a second. Additional surgeons and physicians at the front door on strike days to support the emergency department with the volume of attendances and the risk to making sure we offload ambulances. Actually, what that's proven is that the patients that are chosen to be admitted are generally the right ones. So we haven't seen a reduction in patient admissions, which pretty much means the medical decisions are the right decisions about who needs to be admitted. If you look at the top right-hand graph, though, you can see how different the length of stay is. And again, I'll go back to my points around the things that impact on length of stay are how sick people are on admission. And we are seeing, you know, higher levels of acutely unwell patients. And I know you'll all know that from your constituents. We're seeing an increased level of people that can't leave hospital when they're fit to leave. We've seen COVID, flu, norovirus, and strep A, which prolongs people's stay in hospital, but also complicates our patient flow pathways, which means we're not as effective or efficient as we could be because of all the infection control management that we have to do. So we're actually just starting to see an improvement in that. It's not as fast as I would like, but I'm hoping that as we start to see a reduction of COVID, although we've had a bit of a blip this week, I think the blip is, and Ruth might correct me, but it's sort of 2 to 3 weeks after everyone's gone back to school, which is why we think we've had a bit of a rise in COVID. But I'm actually hoping to see a reduction in that length of stay so we can get flow moving, because at the moment the challenge is we discharge less people than we admit, and that's where the imbalance lies. And while mathematically it might seem like a simple equation, you have to, you know, people have to be fit for discharge, clinically fit for discharge, and that's where some of the challenge lies. Our medical directors have been working really hard on day before discharge planning and making sure everyone's ready and everyone's clear on their discharge plan. And what we've been able to do in January, given that we've had this sort of capacity improvement where everything seems to have got better all at once, is we've really motored on with some of our improvement projects. And we are seeing a much more consistent level of discharge every day. But it's still not enough to stop us from holding patients in the department waiting for a bed. It's better, but it's nowhere near where it needs to be. And we've rehearsed many times the existing bed deficit in the hospital. You know, we've got an urgent and emergency care bill to come in because we know we need a bigger emergency department. So we're trying to be as efficient as we can, knowing we've got some constraints as well. Next slide, please.
And
Stop.
certainly one of your
Hold.
constraints is that, of course, you're dealing with several authorities that you need to get people out to. It's
Yeah.
not just Plymouth, you've got Devon as well as Cornwall as well. So I can appreciate that, you know, everybody is trying their best there, but sometimes the sums just don't add up, do they, to help you really?
No. And what I would say, Chair, is that we've seen significant improvements in both Plymouth and Devon's patients that are delayed, but we haven't seen the same level of improvement in Cornwall. And that's one of our critical areas of concern and scrutiny at the moment.
Thank you.
Next slide, please. This is just our a slide showing you our acute assessment unit. So for those patients that don't need admission but need examination or tests, that would mean that we could then return those patients home with support and with a treatment plan. We have an acute assessment unit. It works really well for some of our frail older population, but it also works well for people who just need coming in, sorting out and sending home. Our challenge is we want to extend that to later in the evening and 7 days a week, and we're recruiting for acute physician consultants at the moment because that's a gap in being able to do that more sustainably. But we have got an improvement plan against it. We are seeing, I think it's in the next slide, I think if we can move to the next slide, in terms of our, oh, I've missed it. Where's our same day emergency care slide for whoever's driving? Go back one more, sorry. One more. Keep going. Let me just find the right slide. Bear with. No, I don't think it's, let me
We
just check,
think it's
sorry.
36.
It is, you're correct, thank you. So I think, sorry, I've just gone past it. So we should see, we're in the top 50%, if we can go to slide 36, the top 50%, bottom right-hand corner, thank you, you were there, yeah. We're in the top 50% of trusts for same-day emergency care, and we know we can do much better. If you look at that slide, 28% of patients were seen on the same day and treated and discharged through that pathway, and in November it was 41%, dropped off in January. In December, sorry. There's loads more we can do with that. We've got active work with our medical directors and our clinical teams to see how we can do even better at that. And what that means is some patients, for example, patients who are haematology or immunology patients, would go straight to their specialty wards. Other patients would come straight to our acute assessment unit for treatment and discharge. So more to do, but we have made very good progress. Next, we go back to the last slide in terms of summary then. So I think just in terms of our actions, so there's the same day emergency care, which I've just spoken to you about, the ED. So you have some detail in your slides about ED staffing, and we've made great strides in the sustainability of our ED staffing. But again, we staff the emergency department with a workforce for a full ED, not an ED that's overfull and completely overfull and managing ambulances outside. So we're constantly trying to adapt our workforce to manage that significant additional pressure that they're experiencing at present. We've got a good recruitment programme, a good education programme, and we're working with Marjons on assistant practitioner roles, which will really help to support the nursing workforce. We've recruited more housekeepers. We've got a hot meal service again. Ideally, you don't want a hot meal service in ED. You shouldn't be there long enough to need one. But at present, because of our challenges, we are just trying to make sure that we cater for everyone. I told you about the ED triage improvement programme in terms of the rat space and the reduction in time to being seen, and the work that we just need to do to continue the focus on those with mental health. So we did used to have CDU, and many of our mental health patients were placed in CDU while they were awaiting assessment and treatment. That is counter to most emergency departments in the country, where mental health patients are managed within the department and within the time frame of an emergency department. We've lost the CDU at present. It's currently used as the halo space, which is where we cohort patients to offload ambulances, but that space will be going for us to build the new urgent and emergency care centre, which was why we initially closed it. And the final bit is we have a business case for an urgent treatment centre on the Derriford site. You'll know that we purchased the land on the northwest quadrant, which is, for those of you that know Derriford site, which is where the Costa Coffee is and the gravel pit car parks. The national team recommended that we have an urgent treatment centre, but we haven't been able to secure funding yet, but that's an active piece of work that we're doing. Thank you.
Thank you. The chair's just had to go out for a moment, so I'm taking over for the time being. Are there any other questions? Now, on that basis, we'll move on. I think we're on to number 8. Is that correct? Fair cost of care. Am I correct or not?
Sorry, we've got a section on discharge, which myself, Sarah, Ian, and Gary will lead on. If I talk to some of the data first, so if we could go on one slide, please. So I think, we've known both nationally and locally that discharging people from hospital has been a real challenge for quite some time. In Plymouth, pre-COVID, we saw good discharge rates from both Plymouth, Devon, and Cornwall. But around 6 to 8 months into the COVID period, we kind of lost that a bit, and we've been in recovery since then. we've made really good strides, and I'll give you some data from today, which shows the improvements that we've made both in Plymouth and Devon. We still have a real issue in Cornwall with the amount of delays that we're currently holding. I think, as Joe's kind of alluded to, discharges affected when we have, you know, COVID, flu, etc., because obviously the community providers, care homes, etc., will go into outbreak as well. We struggle to be able to take people from wards and discharge them. So we had a really difficult period over Christmas, and another difficult period with the power outage, which obviously also has an impact on discharge. Where we need to get to is, you know, discharging more people than we admit, and unfortunately with the amount of people that we have remaining in hospital beds, that doesn't give us the balance that we need. Could we go down one slide, please? So when we talk about discharge, we talk about no criteria to reside. So that is anyone that is in a hospital bed that shouldn't be there, that should be elsewhere. And our target is to get to 5% of people in pathways 1 to 3. So you might know them as complex pathways. The graph there on the left-hand side shows pathway 0, and those are people that are leaving hospital with no care needs. So in terms of community, Plymouth City Council or potentially third sector providers, they can leave with nothing, and they make up around 80 to 80% of the discharges from hospital. The area in which we focus is those complex patients or patients in pathways 1 to 3. And the idea is we get to no more than 5% people delayed in a community hospital, in the acute trust. If you could go down another slide, please. Yeah.
Sorry, Will, you wanted to ask a question on that slide?
Sorry, just for the uninitiated. So the pathway, so that just to understand.
I'm just going to, I'll literally just talk to them on the next slide for you.
So that's a patient, someone who's discharged from hospital that they need something, other care going on to get home, whereas the P0, that's somebody come out of hospital and as far as
absolutely,
you know, when they
can just leave,
they're fine, and the other people need support. That's okay.
And there are 3 different pathways. So there's pathways 1 to 3 for those people that need support. Pathway 1, to put it in simplistic, people that are going home with some wraparound support. Pathway 2 and 3 are people that would normally go into bedded care, so they might go into a care home, a community hospital, short-term care centre. The pathway 3 element is the more specialist element of that, so people that might be going in, for instance, in a specialist dementia unit. Does that help?
Yeah.
Thank you. So yes, it's been a difficult time, and I think in terms of the way we approach it, we do it as a collective. So it's really important that the community, Plymouth City Council, colleagues, and indeed voluntary sector organisations are involved in supporting. In terms of where we are today, as I said, we've got a target of 5% to achieve in terms of those delayed discharges. In Plymouth this morning we had 22 delays. In Devon there were 8. That's the best I've seen it probably in 3 years, and it enables us to go under that 5% target. What we do have is problems with discharge in Cornwall, which we work with colleagues, and they're on 47. So there's a way to go, but there's a lot of green shoots, I guess I would say, in terms of the flow that's coming out of the hospital. Do we want to move on to the next slide and pass over to Ian? Yeah, sure.
Yeah, so I'll pick up the final 2 slides. Just before going through them, the work that we'll cover here sits under a programme of work. So the governance for all of this sits with myself and Joe as the senior responsible officers, and we have a programme which at the moment is called our Discharge to Assess programme. Also has Gary and Chris are part of that group. So the oversight of all these actions sits with reasonably senior leaders across the system. And so I'll try and talk you through reasonably clearly, because I know we tend to use a lot of jargon in here. And obviously, if there's anything you want me to explain, happy to do so, what that work is focused on. So the first section really is from a capacity perspective. There's an overview of the additional resource put in, not just for this winter, but over time, to try and enable some of that discharge improvement work to happen. So as you heard just now, hot off the press, although I do religiously look at that number every day, and unfortunately it does move around a little bit. It has been coming down consistently. So all of that extra capacity is obviously doing its job. We don't sort of rest on our laurels, and we know that the next week could bring something very different. So this programme of work is about keeping momentum and actually continuing to explore how we can improve, but not just the rate of delays and discharge, but actually the outcomes for people who move through that system. So very much also focusing on what happens after hospital as well. So obviously today we're just covering the discharge, and that's a good news story, but we follow that story on into the community to make sure we understand how many of those people are making it back home, how many people are waiting in other care settings that they don't want to be in, quite frankly. Just to pick out the short-term care centre, which I think it is there now. It's Patricia Invention Centre. We received an award and recognition for that service, and there's been a lot of interest from other parts of the country in that model, and that is a perfect example of whole system collaboration with Age UK, Live Well and the council, and I think that's something for us to shout loudly about. And we've had some really great stories as well of people that have gone through that unit and some really good outcomes, particularly the relationship with Age UK. So I thought that'd be a good one to pull out. I think we talked about virtual wards earlier a little bit. And there was a reference, I think, on item 4 to the urgency and emergency care strategic direction of travel, and we are expecting that to become an area that will be invested in more heavily, and we're already looking at how we can do that and tie that in with our urgent community response team. So if we can just move on to the next slide. So this again, there's a lot of terminology in here, but the actions here are all parts of that big programme I talked about before, the Discharge to Assess programme. So the first one is around relationship building and cultural investment. So our colleagues, Live Well Council colleagues, have had additional investment from national teams to facilitate improved ways of working. So as you can imagine, when a system is under the sustained level of pressure that our system has been under, it's really important to invest in those relationships to help people to come together, collaborate and share some of their challenges, and that's been a hugely successful piece of work, and has now led to a really cohesive group of senior leaders working across the local authority, Live Well and UHP. The community decision maker pilot, so before COVID hit, there were a reasonable number of social workers actively in the hospital seeking to discharge patients. When COVID struck, they were ordered out in the politest possible way, as was everybody that didn't need to be in the hospital. And what we've recognised, along with lots of other areas, is that reintroducing that skill set and knowledge base of the community, but also enabling people to have choice and control over where they leave hospital is essential. So we've been introducing more people back into that part of the process, whilst also trying not to hold things up too long and do most of our assessments outside of hospital. I'll pick up probably one or two others. The work around community hospitals, so our UHP colleagues have, again, coming back to last winter in particular, the volume of people moving through the system did see the length of stay in those hospitals increase, which of course then creates blockages for people that need that pathway. And that work, which is now pulled into this programme, is starting to see that number come down, and the leaders from within that service, who are UHP, are also part of this programme group. So Live Well, UHP, local authority, all working together to try and improve that, but also agreeing the priorities for improvement and making sure, as I say, we don't drive the metric to just move people through at the cost of good outcomes for people. And finally, the end of life pathway. This is one that's in development, but we have recognised that there are people moving through the discharge system who are approaching the end of their life. James mentioned the definition for pathway 3, so that would include people for whom
they're approaching the end stage of their life, and that's an area that is developing interest from St Luke's as well as colleagues in UHP. So we're at an early point in that one, just to say, are we getting it right? Is there more that we can be doing?
Thank you very much. Obviously, we've got the capacity and the monies that have been made available for the winter pressures, etc. Now, the meteorologist will tell us that winter is coming to an end, so presumably that means some of this funding won't be there anymore. So are we looking at developing plan B as to what happens with that short-term money that we've got running out, and what's going to be taking its place to keep some of this, because that's we're going to end up with being back to square one, aren't we, when we haven't got that money to fund the ongoing things?
So we will be seeing more money next year for the following 2 years at similar levels and indeed increasing levels. So I think our focus now is already on next winter. We need to get through this winter, but we need to put steps in place and the right capacity in place to get us through into next winter. So for instance, at the moment we run a care hotel, which many of you might have seen. It was quite high profile in the press, and if I'm honest, we want to be in a position where we have other services so that we don't need to do that. So we're working with colleagues in Plymouth City Council around increasing provision for the Home First service, which takes people home. We've increased another service which is quite similar that runs out of UHP called Hospital to Home. The short-term care centre option that we've got at the moment is something that we're looking at. We want to increase that. So all of these discussions are ongoing. We know that we're going to get some more money for at least the next 3 years. So that will enable us to continue. With all the services that we're undertaking, all of our discharge services, we're currently undertaking a review of their performance, just to have a real stock take, because what we did through COVID was there were a lot of plasters that we needed to apply during that period just to get us through, different services set up. So it's a really good time to take stock now, so that ahead of next winter we can get ourselves into a better position.
So, John, coming back to you now, you've got that political headache at the moment of making sure that these things keep going along. Are you confident that we'll be able to keep the numbers down that are delayed in hospital, that we'll be able, that the system that we as a city council have got into operation can cope with this?
Thank you, Joe. Well, I feel much more optimistic in the last week or so, because the figures this year have improved. I mean, apparently January was not as bad as last January, and things seem to have improved considerably as we've got into February with discharges and keeping people at home and getting them out of hospital more quickly. So, I mean, the money is not going to suddenly stop in a week or two's time. It's a programme going on into the spring, and as James has said, other provisions need to be made so that we do things perhaps differently next year, as well as some of the same things that we know work well. The care hotel we've had for 2 years. If we need it again, I presume we will have it again. So, I mean, I'm much more optimistic than if you'd spoken to me 10 days ago or 2 weeks ago, or certainly a month ago. So, yes, I think the team and everyone in all aspects of the health service and the city council have worked together with voluntary sector and other people using the money that has come to increase capacity, which, considering we do have a problem with workforce pressures, I think is quite an achievement.
Okay, thank you. Any other questions that you want to be asking at this stage? No? David, you're sitting back there very quietly, which is unusual for you. And just sort of, how do you see general practice fitting in with all of this? Because I don't know about any of my other colleagues, but I am still getting concerns whilst nurses and other areas within general practice seem to be working well and you can get appointments reasonably well, it does come back to trying to get an appointment with a general practitioner is still hitting a lot of people hard, and they're not being able to just to walk into their surgeries any longer and make appointments. So sort of how are you helping to move things along within general practice generally for that?
Well, that's a very good question. It's a very broad question in terms of the access. When we've talked today about access to a key part of urgent emergency care sustainability is access to services. And I think last time I was here, and to be clear, I'm talking as a local GP. I'm here very much to help field questions around the urgent emergency care agenda with my work within the Integrated Care Board, but I think I can answer that as a local practicing GP. I mean, I'm a partner in a practice that provides services to over 40,000 patients on the east end of Plymouth and the surrounding South Hams and West Devon. And I think last time I was here, I was talking about, you know, and there's been a perennial theme in discussions today, which is workforce, workforce, workforce. So I think any plan is part of discussions right across the country, but Plymouth is very much at one end of a normal distribution curve in terms of the workforce that we have available, which is broader than just GPs. So I think there is a principle here, which I fundamentally believe in, which I think has come out in some discussions that we've had here today, but also in this scrutiny session previously, which is continuity is absolutely crucial. There's a lot of evidence to show continuity translates into improved patient level outcomes, reduced hospital admissions, improved patient experiences. The stories that I've heard a number of counsellors describing before, where increased fragmented care impacts continuity, impacts patient experiences, impacts patient outcomes. So that is at the heart of all of this. But to be able to do that, what we have to be able to do is not just attract, but retain GPs, nurses, paramedics in the general practice workforce. And there is a real challenge at play in terms of the sessional workforce against substantive long-term positions working in general practice in Plymouth. There are a number of things that are happening to address that, including number of training positions. Training posts for GP registrars have never been higher in this area than they are now. But again, that doesn't deliver the workforce overnight. I think Sarah Pearce described earlier around growing our own, really, around Plymouth being a fantastic place to live and work. And I think we have to reframe the narrative around that. I feel it is happening slowly, but it is very, very slow. And so I guess as a committee like this, what we need to see is numbers on seats, really, because that is going to be absolutely crucial. So if I reflect on my, I became a partner in a practice 7-8 years ago, and we still try and retain the registered patient list. It's something I fundamentally believe in because it gives me professional satisfaction of again, feeling like I'm making a difference, but also my learning and progression as a doctor, because getting to know my patients, interacting with specialists, that's how I learn, and that's how I develop, and that's how I feel that I progress and make a difference. But that's become harder and harder to do, if I'm speaking absolutely candidly, in that space. So there are a number of things that are happening to address that, including training positions. The other thing that has happened in terms of immediately in the here and now, because you can't generate a workforce in a day or a week or a month, is there has been some dedicated capacity towards what's called acute respiratory hubs, which is in the winter pressures often centre on significant volumes of people with respiratory tract illnesses. That, I'm sure, is what Joe will be describing, colleagues in the ambulance sector will be describing. And it's really important that we can respond to that with sufficient capacity in the community. So there's been some dedicated capacity within general practice to very much address
those elements. It's probably something I think previously we had a dedicated session on general practice because there's so many different facets to it. And I probably spared the room from carrying on talking because there may well be some specific questions about that. But it's a work in progress. There aren't any easy answers. It's about focusing on where do we want general practice to focus their efforts on, but also partnership, working with colleagues in the community in the ambulance. That is absolutely crucial. But fundamentally, for it to work for patients and individuals, we have to both attract and retain the workforce. And to do that, it has to be an exciting, prosperous, rewarding, professionally satisfying, lots of terminology place for people to work, which I feel optimistic it can be, but it's making that a reality, really.
Thanks very much for that. And I think one of the things that we need to note is that we've received this report about urgent and emergency care. And I think one of those outstanding things that we want to do is to make sure we hear again from Health Watch when they've had chance to reassess with all of these the practice that's been put into place to try and reduce the pressure on ED is absolutely amazing. Sarah, all of those things that you're saying about there, it's got to be brilliant. So I think being a bit unfair on David and sort of pulling him in like that and asking that question I think to me that is the next stage, that we have to have an update on that survey that Health Watch did, and we were concerned about very much. Is got to be another recommendation from this committee that we have an update on that, and hopefully I would suggest within the next 3-ish months as to that being commissioned. I think that would be really useful. Ian, you've got a question.
Thank you, Chair. Today we've heard a lot of positive initiatives, and it does give you a lot of confidence about people who are actually getting down to the nitty-gritty. But I think on the GP front, there's a perception of one day we'll get back to normal, particularly from the public, because they remember the old practices. And I think there's a need for GPs to a degree prepare people, because I think the reality is probably we won't get back to what we always perceived as normal. And I think there's a failure to inform people to a degree about what will be available. I mean, my GP, I can see a nurse anytime. There's lots of positive things, but there isn't that connection between a GP. I've heard you speak about this in the past, and I admire, your way of looking at patients. But the reality is, we're not going to get back to the old world. It's probably going to be a new way for the public in particular to be treated. And I think we're failing to actually inform them, because, I guess this works with the hospitals as well. There is a perception we'll get back to normal. And most of us know, with the knowledge that we get in these committees, that's the hospital to get back to what we perceive as normal is a long way in the future and a huge investment. And I think to a degree, GPs are the same. And I think we need to inform people so that they don't think there's this get back to normal situation. I think people need more information, particularly the public, because they don't attend these meetings. So I don't ask you to kind of cover all that, but just cover the point that we need to inform patients of what they're likely to get in the next 2, 3, 5 years.
I mean, I think that's a really valid point. I think general practice, I think we need to determine what the future of general practice is. And I think that the health service, I think we've heard this afternoon right across the board, there's nothing like the challenge that the health service has faced as it's facing now to drive innovation and change, and what might be the right answer. And again, you'll see innovations and differences across a city like Plymouth. So if you're in St Budo, it might look a bit different, and the challenges in St Budo might be slightly different to in Plimpton, for example. So, and I think that's a valid point. So it might be that if I just take, just as an example, my own practice, the question is, who are the people who are, you're having to make some decisions around who are the people that are likely to benefit the most in general. And of course, there are always the exceptions to every rule, and whatever system you put in place has to be sufficiently flexible to pick out the exception to the rule. But who are the people that are going to benefit the most from having GP input? And a GP organisation is far broader than just GPs, going back to what we were talking about earlier. So the approach that we've taken as a practice, where our list sizes, again, like I said, over 7 years, my list size has increased by 50%. So I have 50% more patients. So I can't be what I was 6 or 7 years ago. That is the reality. So yes, it hinges on recruiting people in, capacity, we talk about retaining people, of course it does. But who are the people that actually I need to be spending my time focusing on? So we've divided our patient groups into 4 groups. And so very much my time is focused on people with multiple long-term conditions. That could be physical and mental health. But clearly I do still work as part of a team. So even for people who might not have any long-term conditions, that has a particular complex issue, may well have a nurse or a paramedic first approach, I still work within the team to support those nurses and paramedics. So I think general practice will become a multidisciplinary team with a GP working as part of that team. It might look a little bit different in different areas. I can't exactly map it out, but I think it's not going to look, in my opinion, things will have to be different to the way they were 10 or 15 years ago. But unless we get the workforce, and unless we retain the workforce, then it's going to be very, very difficult, really. So that's probably not answering your question, but I think it's just that's the approach we've taken as a practice to how we try and best provide the best service we can with the doctors, the nurses, the paramedics and the pharmacists that we have within our team that works for patients, works for the people working in it, because if it doesn't work for the people working in it, then you lose those people and then you're, chasing your tail, aren't you, really? So
thanks, David, for that. I think what we need to be looking at is an appropriate care strategy and how we move forward on that. And I think that's something that, again, a recommendation that we take this forward at a future date. So, yeah, thank you very much. I'm going to call a 5-minute break now, and then we're going to move on to item 8. Okay, folks, just so that people can call us back to order, simply because it's turning into a long meeting, and I don't know about anybody else, but my blood sugar is dropping, but still. Okay, right, so Mariah, welcome. You've not been here before, so welcome. And James, I gather you're not Ross Johnson, so I do.
Oh,
Yeah, you couldn't have got away with that. Whoever's, you need to turn the sound off. Okay, excellent. Right, Anna, I presume it's your, I was going to say baby here.
Thank you, Chair. So I don't know whether it's my baby or not, but anyway, thank you for the time this afternoon. Our agenda item is very much around providing an update around the fair cost of care work and also the development of our market sustainability plans. For those members of the committee that are new, I'll just start with setting a little bit of context, just because that would probably be helpful, I think. As part of the adult social care reform agenda, all local authorities were required to engage with their providers of over 65 services to complete a fair cost of care exercise. So that was for older persons' care homes and also for the home care market. And we started that work through the summer of last year, through engaging with providers. There were a set of nationally set documentation to really break down the cost of delivering care both in the home care market and the care home market. So we're here this afternoon to provide you with a bit of an update in terms of that work. We were required to publish our final findings on the 1st of February, so they've been completed and submitted, so we'll give you an update on that. And also, as part of the adult social care reform agenda, we're a requirement for all local authorities across the country to develop their market sustainability plans. So you might see in our presentation, and I know that Chair in particular always brings us to account in this when we put in acronyms, you might see MSP in our document, so apologies if you do. That is market sustainability plans. And what those plans needed to do was to start signalling where we had gaps in our care market, and some of the work that we would want to do with our providers to address those gaps. So well rehearsed through this committee, we know that we have a shortage of home care in the city. That manifests itself in terms of people waiting for domiciliary provision, whether that be through leaving hospital, and we've put some alternative arrangements in there, but still there are delays in relation to domiciliary care. And what we also know as a city is that we have gaps in relation to our care home provision, in particular for complex dementia care. And what that means, unfortunately, is sometimes we end up having to support people to placements outside of the city. We know that that has a detrimental impact both on them, but also importantly to their families. So our market sustainability plans start to suggest how we will address some of those challenges over the next 3 to 5 years. So I'm going to hand over now to Mariah and James in terms of anything else that they might want to say. You've got the slides in your pack. What we've tried to do is describe the current market in terms of home care and care homes, and then also share with you some of our thoughts in terms of how we might shape the market collectively in partnership with those individual care providers over the coming months and years. We've started to engage with our providers, so we're running a series of sessions with providers to talk about some of the gaps, to talk about how we'd like to work together to address some of those gaps, and also to start the negotiation and fee setting process for April of this year, where we'll be looking to uplift contracts. And for those people who did tune into budget scrutiny, they'll clearly have seen that Councillor Mahoney and myself were able to announce that we're looking at circa a 10% uplift in relation to home care and an 8% uplift in relation to our care home market. So I'll pause at that point and hand over to Mariah and James for anything that I've missed. Thank you, Chair.
Thank you, Hannah. Thanks, Chair. Afternoon, everyone. I think you did get a copy of the slides some days before, so I won't do death by PowerPoint. It's all in there. I think from our point of view, what I probably will just give you is highlights of the fair cost of care process, and also the highlights of the MSP with regards to the care home care market in terms of those two areas. So I think with regards to the fair cost of care, meetings were set up in June last year to collate information from the range of providers that we have within the market. And there were some responses from providers across board in terms of care homes and home care. But I think one of the key issues that we had was looking at how robust that information was, given the number that responded. So even with that, there was quite a lot of discussion in terms of the reflection of the information that was sent through and how that would feed through to something that was realistic. And we've spoken to the providers about this going forwards. I think with regards to where we are with the fair cost of care process, as Anna said, we have had, I think, 2 sessions at the moment. We had one yesterday, we had one today, in terms of looking at that process that we've just briefly described to you now. And also we'll move forward to look at what we then use those funds for going forward in the new financial year. In terms of drilling down slightly to the MSP overview for care homes, I think what I will say is that the care home market within Plymouth at the moment has gone through quite a rocky period, as all providers have found. And I think from our point of view, there are some key gaps which Anne has highlighted already, so I won't go through that. One of the key aspects of our model is to make sure that we look at how we provide the right type of beds and the right type of provision for those gaps. In terms of home care, I think there is already information there for you, but I think one of the key things we are very aware of with home care is that providers seem to be stretched a little too thin across the piece, and what we want to do in this new world as we look to bring a new model forward is making sure that providers are closer to clients and making sure that they are working in a zoned approach. And you know, I'm happy to explain that in detail offline, because I know we've obviously taken quite a bit of time going through the whole process. And I also think in terms of looking at plans for addressing the sustainability within the challenges that we've highlighted, there are key things we have sort of highlighted here, but one of the key areas that I'd like to bring to your notice is looking at how we work on the workforce issues, which I know has been mentioned time and time again throughout this scrutiny meeting. So that will be a key focus for us going forwards. I think that is okay for me for now in terms of key areas. James?
I guess the only bit that, thanks Chair, thanks Anna. The best that doesn't really come across is, although we ran the sessions through June last year, we extended time to work with homes and domiciliary care providers on an individual basis to understand if they weren't engaging, why they weren't engaging, and to give them as much time as possible so we can build up the response to give us as best example for the fair cost of care exercise. We found, as you'd have heard through different people today, that a lot of the responses for not engaging weren't around lack of trust or faith in the exercise as much as around capacity and ability to be able to engage with it. The impact in there of COVID and other pressures was such that many weren't able to through time pressures. Is also reflective of the local market we have here, where there's a great number of locally owned providers who maybe don't have such specialist in-house professionals to help them with such. So there's a couple of examples where we didn't get as many as maybe we'd have wanted, but we did give them as best opportunity to engage as we could. Thanks.
So I think just probably important for committee to understand that we're not unique from a local authority perspective in relation to the level of engagement from providers with the fair cost of care exercise. So it's quite interesting. I think as we set about our planning, we thought we need a huge team to be coping with all of the influx of information that we would have from all of our providers, and we resourced that accordingly, and then actually found very quickly that the level of returns from the provider market was really quite small. And as James I think has described, despite a lot of additional effort and engagement. So James personally one-to-one phone calls with care homes, encouraging them to complete the exercise, the home care team the same, linking in with providers, urging them to complete the assessment and analysis work. So we find ourselves like all other local authorities, certainly that I've been speaking to in my new DAS role, Chair, that we don't have the sufficient information to be able to use the fair cost of care exercise in a way that it was originally intended. Therefore, it leaves us in the position whereby we are needing to embark on fee negotiations despite the findings of the fair cost of care exercise, because actually it is not valid in terms of the level of return rate. So we are, like all other local authorities, engaging with the market to set our fee rates for 23-24. I think it's important to understand where Plymouth sits in relation to other local authorities. Thank you, Chair.
Thank you, Natalie.
Thank you, Chair. It seems like an obvious question. How many returns did we get then? Because you said
Circa 30% across both markets, so 30% of providers across domiciliary care and 30% for care homes.
And is there any way that if it's done again, I don't know how often you do it, whether it's on an annual basis or that it can be done in a different way or made easier? Have you had feedback about what were the difficulties? I appreciate you said some of it might be capacity, some of it might be trust, but is there a way of making it more accessible so that actually more will engage with it?
So the assessment process was set by Department of Health and Social Care. So it was standardised methodology that was rolled out nationally. Clearly, we attended the design sessions in terms of the approach that Department of Health and Social Care wanted all local authorities to take. And I think we did reflect that the position of the market in terms of its capacity would mean that actually it may be quite difficult to complete such a comprehensive approach. And there were some changes made, but nonetheless the methodology was set nationally. And I think that was because there was a desire through the fair cost of care work to actually have that national view rather than looking at it on a local approach. So clearly, traditionally, local authorities have set fee levels on a local footprint. The fair cost of care exercise was very much about bringing that together nationally.
It does happen periodically, doesn't it?
So in terms of fee rate negotiations, we obviously negotiate each year, Chair. So every year we look at cost pressures across our market and we work with providers to do the best with the finite resources that adult social care has to address those challenges. So yes, of course, this was the first time that there was a national exercise around trying to bring together an understanding of the cost of care across the social care market.
Sue, did you have your hand up there?
Well, I was a bit confused, Chair, that we send people to care homes, citizens mainly of Plymouth, and we can't actually get any information out of the care homes when we might be supporting them financially. I don't understand that. And I also don't understand the methodology of finding this out. How are we going to make sure, if it is changed, that it's valid and reliable?
So, so apologies, Councillor MacDonald, if what we've presented is that we don't have information from care homes, so we absolutely do. So our care homes report back to us in terms of vacancy levels, staffing levels, quality levels, all of those types of things, absolutely. What we're referring to is the very specific exercise in relation to the fair cost of care and the analysis or the documentation that they were asked to complete but not mandated to complete to engage in that process. So clearly through our contractual arrangements that exist with our care homes, we have a huge amount of data and information, but this was a subset of breaking down all of their costs. And clearly that was, you know, it wasn't mandatory. It was, you know, they had the opportunity to engage in that, and many of them chose not to engage in that.
Ian.
A very quick one, because I remember, you know, when I was a cabinet member, how care home owners weren't slow to inform me how what the council gave them didn't cover anything near costs. So I find it strange that when they get the opportunity to share that information with us, and I suppose the serious question is, do they lack confidence that it will make any difference? Because it's quite amazing that they don't want to take part in this, and it's quite amazing that it might be to their advantage. I mean, it might be to their disadvantage. But I find it a little bit strange that care home owners aren't using the opportunity to lay out their cost and effectiveness. So it comes as a surprise that they chose not to do that. I don't think there's a question there. There might be, but I'm just astounded, if I'm honest. Thank you, Chair.
John, did you want to come in on this?
I don't have anything to add as to why they have or haven't responded, but I agree with Ian Duffin that I always thought they were claiming that they were underfunded, particularly the patients that were being funded by the city council. And of course, one wonders in this whether there's not then a cross subsidisation going on from private funders who are paying more and bridging the gap. But this is, I suppose, what this exercise was hopefully nationally and locally going to establish. But it doesn't seem that perhaps it's quite had the effect it might.
I mean, it's reassuring to know that we're not alone in this, that a lot of other authorities have found this conundrum the same. So, yeah, Mariah, did you want to come in there?
Yes, thank you, Councillor. I think from my point of view, given the 2 sessions that we've already had in terms of the engagement post the Annex B, is that we've had quite a good turnout of providers that have come to these online sessions where we fed back to them exactly the information that we are feeding back to you. So today on the call we had, I think, about 3 care home providers. We had several supported living, so all in all about 8. And yesterday I think we had close to about 4 or 5, and we've only just started a session of about 6 that are going to continue into February. So they are responding in terms of engaging with us going forwards regarding, how we then move forwards with the funding application.
Will?
So there seems to be quite a bit of information. There's a slide here on recruitment and retention, but some of this information is perhaps commercially sensitive. It's if a provider provides services to the council at a price, how they spend that money is that's how they manage. If they say they can do it for a said price, that's the business of the private company. But where you've got in the previous section of today, there's an at-risk, which is on red. I don't know, for earlier today, of market failure. I mean, do we look at what it would cost the council to do to have this as an in-house care home or in-house service? Is that looked at as a base?
So I guess there's a few bits in there in terms of market failure specifically. Just to answer your point, the council has looked at that. It's looked at that very particularly in the dom care market where those risks were highest through this period, predominantly with workforce issues, cost of living, and that employment was better, although not ideal, in the residential sector of the dom care. And what the council did a number of years ago, and I came and we presented, and we set up actually a care company. So we're not part of the council, but owned by the council. So we went that kind of middle ground, if you like. That has already taken 2 permanent. It's actually taken 3 market failures, but 2 it's kept in terms of providing a domiciliary care service for people, and 1 it helped facilitate looked after those people whilst the market could recover to the point where those people could be looked after. So I think that's probably quite important for us, because we do look at those risks and we take those really, really quite seriously. It's interesting, I would agree, that in that market where there was a national programme announced to try and look at fees, recognising that it is a challenge to operate in a domiciliary or a residential market, that you don't quite get the engagement as one of the mechanisms to help, even if it doesn't drive the fee rate conversations and negotiations, to help generate the understanding in the marketplace of where you need to maybe be striving to get to. So it is, we would agree that was, in terms of turnout from providers, difficult. It is their money, isn't it? National providers tend to describe their finances differently to micro providers, and I think those were also some of the issues that came out with money.
Mariah?
Thank you, Councillor. I think, Councillor Noble, one of the other key areas for us is how we perceive that market failure and how we are more proactive in terms of making sure that we are in sync with what is happening in the market before it actually becomes a failure. And one of the things that certainly Anna has tasked me and a few others within the commissioning team to do is to look at developing a more robust system and process, which is a combination, I wouldn't want to bore you, but a combination of qualitative and quantitative indicators, where we'd sit round in a multi-agency setting with CQC, with LiveWell, to actually look at these indicators and begin almost to predict where certain providers are going. And this is something that we've already started working on, and actually will be launching in a much more broad sense with regards to the figures I'm talking about, probably in the next couple of weeks. So we already do that, but I think one of the key things that is prevalent is that we need to be getting ahead of that failure before we actually sit round a table and call it a failure.
And I suppose, Will, that brings us back to that risk reporting, monitoring reporting, that perhaps we ought to have considered that there may be something on that risk register that needs to be looked at further, and probably this is one of those things. So I think we need to put that bit in from that risk register monitoring. Okay, as well from that. So, looking at this report that we've got now, obviously we need to note the outcome of the fairer cost of care work. And secondly, we need to support the proposed approach to fee setting providers for 2003-2004. And thirdly, to note the strategic direction as set through the emerging market sustainability plans. This is something that won't go off the radar at all. I think thank you to the team for your very brave try at getting some further answers for the Department of Health and Social Care, but we accept that it wasn't the easiest thing to do. So thank you for coming along today. Do appreciate that. Thank you, and good to meet the pair of you. Thanks. That brings us on to item 9, which is something that came as from the motion of notice that was raised about defibrillators. So, where do we go with that? Who's doing that? Elliot, is that your idea? Or not your idea, but what's come through you?
I'll take that one, Chair. So the motion on notice went to full council and was referred to this committee, stating not all our public buildings have a defibrillator, and it's essential that this value piece of equipment is on site here at the council house and other council-owned buildings across the city. We recommend to Cabinet to make an allocation within their draft budget for this completion. So today, we haven't got long as a committee, roughly outline how we're going to take this forward. So really over to Anna and ourselves to discuss whether we want to break this down into a small task group, whether we want to add this as an agenda item going forward, and we'll do some work offline to actually come up with the materials. Thank you, Chair.
Ruth, did you want to come in on this?
I can do. I do have a little bit of background information that I managed to pull together, if that's helpful. It's not my biggest expertise, but clearly the issue with this is that they're not needed very often, but when they are needed, they can save lives. So that's the conundrum that we have. I pulled some data which suggested, if I relate it to Plymouth, that there are something like 140 cardiac arrests in Plymouth in a year. So that's only 1 every 2.5 days. And the majority of those happen at home. So something like 3/4 or so will happen to people at home. So there's quite a small number that happen out of hospital and out of the home environment. But what's really difficult is, of course, you can't predict where people might be. And there's no specific tool that sort of says, if you have X number of people passing this area, it's a good idea to have a defibrillator. What we do know is that, you know, every minute counts with something like this. So being if a defibrillator is used within 3 to 5 minutes, the survival rates increased from, virtually, well, very low, sort of 6% I've seen quoted, up to something like 70%. So it does make a very big difference in terms of lives saved. So you have the possibility of a fairly rare event that may happen, but a big success rate if that situation was to arise. So the difficulty comes with, where do you put defibrillators? And there isn't any clear guidance on this. It is really up to us to form a view of where we think they might be a good idea to have them. And there's some guidance on where they might be. Clearly, you're looking for places where there's a relatively large throughput of people. Clearly, you want them to be accessible. And although there are some that are in locations where they're not accessible if the place isn't open, there are others that you'll have seen on the outside of buildings where they're in a locked cabinet that can be, or a cabinet that's maintained that can be accessed out of hours, or at any point 24/7, which clearly makes sense in some locations. So there's a bit of a question for us about, are we doing it in certain buildings for staff? Are we doing it in certain buildings because we think the community may be able to access it, in which case it probably needs to be on the outside of the building? And a bit of a balance about how much they cost and what the costs are to keep them maintained. I don't have the answers, but those are the kind of things we need to go away and look at, I'd suggest.
Can I just sort of thinking from what you've said there, Ruth, that there's something that needs to be a very short and sharp task and finish group. And I don't profess that we have all the answers on that at this stage, but I do think it's something that needs to be done quickly rather than leaving it dragging on. So would the committee be content that if Anna, Elliot and I had a conversation and then came back to you via an email to see what's best? But I do think that it needs doing before the end of this civic year. Are you happy with that, Sue?
Sorry, Chair. I had some experience of defibrillators, both as a coronary care nurse, but that was so long ago. But also in our local neighbourhood, there's a defibrillator at Devil's Point. The problem is you can train people to do it. People turned up for the training, but there's not been anything to continue that. And so if you don't get regular training, which has its own cost to keep, because you might only use it once in a lifetime, yourself, but if you happen to be somewhere where you need to use it again and you haven't been trained for a long time, then you're going to be nervous. You're not going to, and I'm not being patronising, but it's quite difficult, I would suspect. And those are the issues. If we're going to put them somewhere, we need to back it with the training and the regular training of those who volunteer to do that.
I think there's accessibility, etc., isn't there? And I certainly know from speaking to somebody else that the various other services used their defibrillator and the batteries were often flat and things like that. So did you want to come in there, Natalie?
I was only just going to add on the account of about the training. First aid training, well, is now defibrillators are part of the first aid training, but also the defibrillator itself talks you through what you've got to do. So it's not so anybody could use it. Yeah. So maybe they might have moved on, because I think there has been changes. Certainly, it's been added to the first aid and training.
Okay, so if perhaps Ruth, Elliot and I and Anna and John have a conversation and see how we feel this is best to go. I mean, I don't want to dismiss this whatsoever, because it certainly is, a very viable thing that we need to think about, but it's some of the other, I think a scrutiny would need to do a one-off investigation. So I've got Will and I've got Lauren. And then John.
on the policy briefing we had earlier, it says new funding announced to increase the number of life-saving defibrillators by at least 1,000, which is on page 3 of that, page 23 of the. So I mean, it maybe having that as part of the, the Plymouth allocation of them. There must be in several buildings that you would think there'd be anyway. But.
Thanks, Will, for bringing that to our attention. Lauren?
Thank you, Chair. That's actually what my point was about signposting. So the only resource I can find is a Plymouth Live article about where our defibrillators are, and it feels like there should be a centralised hub maybe on our website. That's maybe something for you guys to take away and see how we advertise those. Thank you.
Yeah, John?
Thank you, Chair. Yeah, they are very easy to use now, and actually they don't allow you to shock the patient if the rhythm is not suitable for the patient to be shocked. I'm sure they all do that now. We had one in the surgery that was rushed down to the Broadway 10, 12 years ago and possibly saved someone's life. Whether there is now one on the Broadway, I don't know. I mean, that's the sort of place that we're not responsible for, but it's the sort of centre. There should be one. I'll try and find out, I think, because they do save lives and they are simple to use. I think the batteries have to be recharged once you've used them, but I think they keep their charge for quite a long while, or some of them, they're continually being trickle charged. So Ruth might know more.
If possible, what I'd like to do is for us to have that initial discussion and then perhaps see if there's enough time to come out with even a preliminary answer before the next council meeting, because I think that would be quite useful. Ruth, would you be happy with that? Yeah, is the committee generally happy with that? So that response, but I think as long as we could get something done by it only takes us to the end of February basically, because I think the next council meeting is I want to say the 20th of March, something like that. So if we can get something back to them by then, if anybody that's really interested in coming forward, presumably Councillor Beer may well be interested because. And you're interested, Natalie, that would be great. But let me just get some initial thoughts together and then we'll put it to you to come back. All right. So, Elliot, if we can organise something. Thank you. Right, that brings us on to tracking decisions.
Yes,
Elliot.
thank you, Chair. There's currently 2 tracking decisions requiring action on your logs. The first one in relation to the ICB, I've had a response from, so I will circulate that to all of you, so that can be now marked completed. The second one is a preparation of the Mental Health Select Committee. We currently provisionally held a date of the 7th and 8th of March, which is in all your calendars. We're working on that to come up with the content and the attendees. It's going to be a 2-day session, cradle to grave, and Chair will have some meetings shortly. Thank you.
Thank you. So that's covering the work programme as well, basically that bit of it. So the work programme is there before you. But of course we now need to add in the bit about the defibrillator into that, definitely. So defib into that. There is a huge amount of bits and pieces that we have there. Is anything jumping out at you that, I mean, the next session of this committee will not be until after the new civic year. And I believe there was a date put on the diary.
Yeah, 27th of June.
27th of June. Yeah, so I mean, it depends on who's on the committee and whatever then, doesn't it? I mean, so I would not like to tie them down too much until the new committee is done. So are you happy that we leave things alone till after the AGM of council to know who's actually on this committee for them to quickly get together? Sue, you be quiet. You don't get DMOB fever yet. I'm sorry, that's not allowed. All right. So okay. Anna.
So I just wonder, Chair, whether you would feel happy if Elliot and I did a bit of a tidy up around the future items, because I think there's elements that could be brought together. So care package, care agencies, some of the bits around workforce. I just wonder whether we tidy that up and bring those together, because there's also a line in here around carbon reduction and the care market. So I just wonder if we extend the brief of those sections. So if you're happy, Chair, I just propose through you that Elliot and I just maybe tidied those up a little bit for you.
I think you're right. I mean, there are some things that, you know, there's a lot of interesting information there that might just, as I say, need a paper rather than anything else to and certainly dental health. I mean, that's going to have to come back. There's no two ways about it. Things like that. I was on a dental masterclass, I think it was last week, and they were saying about there was something like 43,700 people on the dental waiting list in Devon. And I must admit, I did put into the chat, yes, 2,800 of those are in Plymouth, because they were implying that you were only on the dental waiting list for 12 months, to which I then put, and I'm one of them, and I've been on the list for over 2 years. So, you know, I think that there is a generality that can be made, and then there is more specifics. So there are things that are never going to fall off this list because they are ongoing issues for our residents, and certainly workforce. That's never going to fall off the list because that's always going to be something. And whilst learning from COVID might not be so essential, there has been a huge learning from COVID and about how we get on with things, and care homes and the care sector due to COVID. You know, so I think, yes, there's a lot of these things that will come together. Adult social care reforms are always going to be. The Cavell Centre, again, is not going to drop off the list because we know how vital that is to not just the West End, but to a whole load of services that for the population within Plymouth, and being able to go there for some of your x-rays or blood tests or whatever, instead of having to go out towards Derriford. You know, there's a whole bit. So, okay, folks. Lauren.
Thank you, Chair. I had a question, and I'm sorry if this is not the right place to raise it, but I've been reading some really concerning national reports about delays in access to abortion care, and that's kind of owing to an increased demand in the service, with more people choosing to terminate their pregnancy because of the cost of living crisis. So we know that opting for an abortion can be like a really difficult and emotionally rough time for people. So I was wondering if we're noticing these increased demands in Plymouth, and if we are, what are we doing to ensure that those services are protected?
Ruth, that would be your area. Obviously, Ruth is. We need to come back to you on that. I think perhaps if you could put just something in writing and forward on to Anna, Elliot and myself, and then we can make sure that we take that forward. Not a problem. It's just making sure that the right person is helping us with it. And but there's no reason why it can't go on a list of things to future items, definitely, for an update. Thank you. Anybody else got anything? No? No? Well, can I say thank you all very much? You've all been really, admittedly, there's two of you that are brand new members to this committee, but, you know, it's been a really busy year with various things, and I certainly think that health and adult social care is not something that's going to go off the agenda for Plymothians, so we will keep at it. We have no exempt business today. We've managed to avoid that. So thank you all very much indeed, and I will bring